webinar on Onco Illuminate 2025 Clinical Updates on Common Cancers. With immense pleasure, I would like to invite Dr. Lalit Sharma, who is consultant medical oncologist at Manipal Hospital, Jaipur, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you so much for that kind introduction. Good evening, respected teachers, seniors, and dear colleagues. At the outset, let me thank you all for accepting our invitation and sparing your valuable time from your busy schedules for this academic event. Now, during these 2 days, we wish to discuss the various nuances of the common oncological disorders. We not only wish to discuss various day-to-day challenges in managing these malignancies, but also would like to lay threadbare the latest data available to us. We wish to learn by conducting fruitful scientific discussions and sharing our vivid experiences to help us understand the intricacies of managing these disorders. In the first half of this webinar, that is today, we wish to start with head and neck cancers, followed by early breast cancer and then metastatic breast cancer. Subsequently, we would discuss genitourinary and gastrointestinal disorders. We have a galaxy of renowned experts from various specialties who have a vast experience in managing these disorders. Without any further delay, let's start this evening with the first presentation by a very dynamic medical oncologist from Sun City, Jodhpur. Dr. Abhishek Sharma is a consultant medical oncologist and hemato-oncologist at Goel Hospital, Jodhpur. He would be talking about long-term survival outcomes with nimotuzumab in combination with the concurrent chemoradiation in locally advanced head and neck cancers. Over to you, Dr. Abhishek.
Yeah, sir. So thank you, Lalit sir, for this good opportunity for me. So today I am going to discuss about the nimetozumab in locally advanced head and neck cancer in a CTRT setting. Please share my slides.
Sir, screens are visible.
Yeah. Okay. So, next. So we are going to discuss about long-term survival outcomes with nematozumab in combination with concurrent chemo radiation in locally advanced head and neck cancer. So next slide, please. Yeah. So basically, nimetozumab is a drug that is a monoclonal antibody against the EGFR. This is the IgG1G3 IgG3 antibody. Basically, this is a drug that is developed by the Cuban laboratories, and it is the most used, or you can say, most versatile drug that is used in Cuba or and other African parts. And the indication right now is head and neck cancer in a CTRT setting as well as some metastatic setting in a that approved in Cuba, Uruguay, and some nasopharyngeal cases in China that got approval for that. Right now, latest adult and pediatric glioma in Cuba as well as China. And so they are approved the nimetozumab as well as pancreatic cancer in India and Cuba and other studies. So that is nimetozumab using in various subside head and neck, you can say nasopharyngeal glioma, and after that pancreatic cancer and other some subsides also they are using the nimetozumab. So in nimetozumab, I have to discuss the phase study study. This is a proper Indian studies. This is published by the Tata by Dr. Vijay Patil and team. So this design, you can see in this slide, the eligibility criteria is well matched, well all as more than 18 years of age. Squamous cell carcinoma of oral cavity, oropharynx, hypopharynx, and larynx is included. Stage third and fourth, no distant metastasis in the patients, and those who are planned for definitive CTRT with adequate organ function is included in the study. And they stratified according to the T group, T0, 1, 2, or T3 or T4, and they are nodal staging, nodal 1 or 2, N1, N2, or N3, and the site is specific like oropharynx versus non-oropharynx, and the technique of radiation, conventional versus others. And properly they randomized to 1:1, open label. One arm is the nimetozumab 200 milligram weekly with cisplatin 30 milligram per meter square with RT. And second arm is the weekly cisplatin 30 milligram per meter square with the RT. So this is the two arm in this study, and follow-up done in this study is weekly during CRT, and after that 3 weekly they done. You can see in this chart the enrollment of the population is around 754 assessed for the eligibility. The randomization population is around 536, and allocation is to the radiation arm is around 268, and the nimetozumab cisplatin arm is around 268 patient. So this is well matched group in a both side, and you can see patient those who have defaulted, patient those who have received cisplatin or carboplatin, that is more or less similar in both groups. And therapy, you can see clearly say patient those who are not completed is around same in both group. Those who are not started on CTRT almost same. Progression of disease during chemoradiation, that is almost same in all group. And analysis, yes, more or less same in the well group outcomes as well as safety measurement. You can clearly see this study is well randomized study, and the allocation is quite good. Therapy is almost similar in both group, and outcomes we have to discuss in next slides. Next slide, please. Yes. So when I talk about the baseline characteristic of this study, the median age of study in the cisplatin arm, you can say is around 54 year, and almost similar in the nimetozumab arm. The p-value of significant for this, and PS you can see 0 or 1 mostly included in this study. That is 99% cases both and same, and ECOG is 2 not included, but very less in not included in both sides, and ECOG 3 or not included in this study. You can see most of site is oropharynx. 50% cases are oropharynx in both arm. Hypopharynx is the second most common site in this study, around 20 or 23%. Larynx is the third most, and oral cavities is rarely included in this study because oral cavity does not have a good CTRT data, as we all know. So oropharynx, hypopharynx, and larynx, that is most common subsite in this study. Mostly disease you can see is T3, T4, around 70% cases in both arm, and T1, T2 is very less, it's around 15-20% cases included. N1, N2 is mostly included, is around 50% is both, and same for N2, N3. And stage third, stage 4A and 4B. You can see clearly. So this study is well baseline matched characteristic in both arm. You can clearly see mostly is hypopharynx, oropharynx, hypopharynx, larynx with T3, T4 with N2, N1 disease, and stage third, or you can say stage fourth A, mostly included in this study, those who are planned for the CTRT, and P value is well matched in both arm. So now, after that completion of therapy, they plan the analysis for the progression-free survival. You can see in this graph, you can say they are very well separated from the initial 2 or 3 months. Yeah, definitely we cannot comment on that. But after 6 months, you can clearly see there is a very good separation of the curve in the both arm, where we can see the nimetozumab RT leading compared with the cisplatin, and you can see at the 42-month and 48-month, yes, there is a clear-cut good separation that is continued. The 2-year PFS is around 50 versus 60% with the p-value is 0.004. This is significant. So yes, this is important for us. The 2-year PFS is good with the nimetozumab. And when you discuss the 2-year DFS, more or less, this is all 48 versus 60% patients and with the significant p-value. So yes, this is showing a good separation of curve with the 2-year PFS is good with the nimetozumab. When you see the forest chart, you can see in the all subgroup is favor nimetozumab cisplatin radiation better than the alone cisplatin, and one and only that old age patient. Yes, this is just to the line. So yes, old age patient we can discuss we should plan or not. But yes, in the all subgroup, nimetozumab cisplatin versus cisplatin, yes, nimetozumab is do better in the all subgroup. Next slide. Yeah. So when we discuss about the local regional control, because when we discuss about the radiation, local regional control should be discussed. So forest plot depict the effect of treatment on various subgroup used for the stratification. Yes. When you discuss same as a curve of the lower regional control, 6 month more or less similar for them both, but after 6 months there is a well separation of the local regional control. When you compare 2-year local control in the cisplatin RT arm, this is around 57%. When you see the for the nimetozumab, it is 67%. So there is a clear-cut 10% benefit of 2-year local control with the significant p-value is 0.006. And when you see the forest plot, you can clearly see local control is better with the nimetozumab in all subgroup where the age more or less than 60, where the site is oropharynx or non-oropharynx, where the stage third or fourth, where the conventional technique or non-conventional or IMRT and other. Those who are the stratified, yes, all are favor in the nimetozumab when we talk about the loco-regional control. Next slide. Yeah. So this is the overall survival group. You can see the overall survivals is also in favoring the nimetozumab. There is a 57 month versus 63 month percentage of 2-year overall survival. And the significant p-value is 0.01. That is not so quite good as a PFS because we know the overall survival also depend on what is the subsequent line we use in our patients. But when you see look for that curve, you can say a very good separation started from the 1 year, and it lead to up to the 42 month. You can see at the 5 year, at the 48 month, at the 4 year, you can say there is a curve is just to more or less same on a both side because the events you can see is very less in the at the 48 month, but yes, up to 2 year or 3 year where there is a very good survival differences between nimetozumab or cisplatin alone. And when you look at the forest plot, you can see the depict the effect of treatment on various subgroup as our stratification like age more than 60 or more than below or above non for oropharynx, say third or fourth. We are using which techniques? So all in favor of nimetozumab. There is only one catch in that. Those who have age more than 60 and above, you can say the elderly patient, we have to choose a single or double with nimetozumab or cisplatin only. Yes, there is a survival benefit is not so good in patient those who have a age more than 60. You can say the elderly patient we can choose wisely when we are using nimetozumab in our patients. Next slide, please. Yes. So this is a subgroup analysis. So one most important part is that when you discuss about the oropharynx and when you discuss about the CTRT, patients, those who have a HPV positivity, yes, we all know that is uh, a good survival, good local control when they compare with the HPV negative patient. So this point should be discussed in this arm also. If those patients who have a HPV negativity, what the result of nematozooid in that patients, those who have a HPV positivity were the result of nimetozumab in that patient. When we talk about the Indian scenario, the most common causative agent, as we all know, this is tobacco, smoke, and this is the most common scenario. When we talk about the HPV positivity in our population, I think this are only 6 to 10% cases are the HPV positive in Indian population. So there is very low number of HPV positivity in the Indian population in the when we discuss about the oropharyngeal cancers. So the proper analysis you can say is very less number of population HPV positive in this trial. So we cannot comment on that. But yes, those who have a HPV negative, a good number of population to have discussed. And this is published in Onco Target in the same study by Dr. Patel sir and Dr. Vanita Narona. So I will to discuss what about their long-term survival in this patients, what is the PFS and all. So next slide. Yes. So this is a subgroup analysis. You can clearly see the variables according to the age, the median age. In a HPV negative patient is 53 and the nimetozumab is around 56. A patient, those who above more than 60 years is around 25 versus 30% in the nimetozumab arm. And when you discover the gender, yes, male and female, both are the well matched in this negative groups. ECOG is mainly considered as 0 and 1. This is well matched in both group. Tobacco using, you can see more maximum patient have a tobacco user in the both groups. 90%. We already discussed the main causative agent and the subset of malignancy that is base of tongue and tonsil, mostly subside in the oropharynx. And that is well matched in both groups. You can clearly see this is around 60% in both groups and tonsil around 30% in both groups. So subgroup analysis of 187 HPV negative oropharynx cancer, 91 in the cisplatin RT arm and 96 is the nimetozumab cisplatin RT arm. So this is quite well matched uh, characteristic of HPV negative subgroup patients. So next discuss about what the PFS in this patient. So next slide, please. Yes. And So subgroup analysis of HPV negative oral cancer 2 year. 2 year PFS, you can see those who patient is a P16 negative, 31% versus 57%. And this big, just give me a second. And hazard ratio is 0.54, you can say, and the p value is around 0.001, and 2 year local control is 41% versus 60%, and the significant p value is around 0.024. And when you discuss about the 2 year overall survival, there is 39 versus 57%, and with the significant p value. So this study depict the patient, those who have HPV negativity, those who have not a P16 positive, they have a very good PFS benefit when you using nematozumab, or they have a very good local control when you have when you are using nematozumab, because there is a 10% improvement in the local control, as well as around 12% improvement in the when you see the whole population. But when you only target that population is HPV negative population, you can see there is a almost double in the PFS at a 2 year, and almost 20% local regional control improved at a 2 year, as well as overall survival also with a significant p value. So this study depicts that HPV negative patient is do well with the nimetozumab. Maybe theoretically it's also proven, because the main causative patient is tobacco, and all they all are smoker, had a high chances of expression of EGFR. So that may be theoretically also proven with this match with with the result also. Next slide. So you can clearly see, we already discussed what is the median PFS is 12 month versus 35 month, with a significant p value in the HPV negativity. When you discuss the local control, there is around 70 versus 60 month in the local control, with a significant p value. When you discuss about the median OS, there is around 19 versus 35 month, with the significant p value. So HPV negative oropharyngeal cancer significantly better outcomes in terms of PFS, in terms of local control, and as well as overall survival by adding of nimetozumab to the CTRT. So yes, for a negative patients, nimetozumab should be added, or should be a good option alone to cisplatin. Next slide. Yeah. So conclusion, subcohort analysis of the oropharyngeal cancer. The addition of nimetozumab to concurrent weekly CTRT improved PFS, local control, as well as disease-free survival. The combination provide a novel alternative therapeutic option to a 3 weekly schedule of 100 milligram per meter cisplatin in a patient with locally advanced head and neck cancer who are treated with the radical intent CTRT. Next slide. So next question is that what about the improvement in the long-term OS was unknown, because when you discuss about CTRT, any time we have discussed about the PFS mostly we have discussed about the 2 year PFS, 2 year OS, 5 year. What about the long-term OS in that patient? So that is also published by the same study. At the 10-year overall survival, they published with the patient with dumotuzumab. Next slide. Yeah. So this is a long-term result of the phase study, same study, that is a publication, and the same eligibility criteria you can clearly see. Next slide. Yeah. So same subgroup site, same stratification, the conventional, but the technique and other technique, you can see that same subgroup, tumor site group T1 to T4 included, same nodal site, N0 to N3 included, and randomized same, it's the same study, you can say. And the primary endpoint of this study was the 10-year overall survival, and secondary endpoint was the late adverse event in the both groups. Next slide. Yeah. So the median follow-up of this study is around 8.86 year. The primary side was the oropharynx, around 50%, and only 24 cases were the HPV positive. So most of the population is HPV negative. So 10-year OS in the CTRT arm is around 22% versus the uh, nimetozumab around 33%, with the p-value of the 0.004, and the median OS around 2.7 year versus 3.69 year, with the p-value is zero point zero 0.04, and median OS in HPV negative patient 1.8 versus 2.4 year, with the p-value of 0.02. So you can clearly see there is a benefit of the 10-year overall survival with the nimetozumab. Median overall survival benefit we can see with the nimetozumab, and median overall survival with the HPV negative oropharyngeal patient. You can see clearly there is a good survival benefit with the significant p-value. Long-term adverse event captured in around 380 patients. There was no statistically significant difference in the late-arm adverse event between the two arms. So basically, grade third, grade four additional toxicity with the nilotinib was seen in the patients, especially the EGF anti-EGFR toxicities like skin toxicities, especially rashes, mucositis. That is little bit high with the nematozuma, but there's no significant difference. And some grade third events are high with the nematozuma, but not so high. That is statistically significant. Next slide. So conclusion. The addition of nematozumab to weekly cisplatin lead to improvement in the long-term survival, overall survival, PFS, local control we already discussed. So this study published long-term overall survival also in locally advanced head and neck cancer without any additional increased long-term adverse event. And these results are largely applicable in HPV negative patients. So my final conclusion about the study. So basically, nimetozumab, one anti-EGFR drug that is useful in HPV negative patient, especially for the oropharynx, and we can use all subset like hypopharynx, larynx also. But the best result you can clearly see HPV negative oropharyngeal cancer patient, those who have a locally advanced disease, and they plan for the see definitive CTRT. So we can add nimetozumab in those patients. There is a clear-cut 2-year PFS benefit is around 10%, 15%, and 10-year, 2-year local control is increased by the 10%. And there is a overall survival also benefit we can clearly see. Then 10-year overall survival also seen in the those patients. So nimetozumab can add in HPV negative oropharyngeal cancer patients. Next slide. Yeah. So thank you all. This is my conclusion for the nematozumab CTR.
Thank you so much, Dr. Abhishek Sharma, for that very elaborate and lucid talk. And we had basically two questions in our mind after that. First was, what are the now that nimotuzumab has been there for so long and we have been using it quite often, what is the most ideal patient you would consider for this particular drug, which you have very well alluded to in your conclusion also. The other question which we would like to know is ki, uh, Dr. Abhishek, do you have any toxicity concerns with this particular drug?
Yeah, sir. So my first question is that sir, this is basically the most data is available with the Indian population, and one you can say the Cuban population because the drug is mostly used in those countries. India, the biggest evidence available in Tata, and as well real world evidence also from the Tata also. So the best patient for this is the oropharyngeal definitive CTRT patients. And if you are doing P16 in the all cases, so those who are P16 negative, they should be considered. So P16 negative oropharyngeal cancer patients is the best patient for the nematozumab. But the when I talk about the adverse event, sir, as this is very easily tolerable drug I have seen in my practice, and I didn't find any grade third or grade four event with the nematozumab like those who are attributed to the radiation. I just found some additional toxicity like skin rashes and some nail toxicities. So that is definitely patient discussed to us. This is what is happening to my skin because my radiation is just given to the this local part, but my skin some develop some rashes. So that additional toxicity we see in our patient. Otherwise, no grade third or grade four toxicity we seen in our practice.
Wonderful. I can see Dr. Nitin Kudreta raising his hand. Sir, could you please
So I've
go
got
ahead?
one question there. Am I audible to everybody?
Yes, sir.
So
Yeah,
my
sir.
question is that this all study which you just discussed is only of oropharynx and hypopharynx and larynx, right? It
Yes,
is
sir.
not for oral cavity, so we should
No,
not
sir. No,
think
sir.
it's
No,
for
sir.
oral cavity.
Yes.
Okay.
The
Second thing,
it,
yeah, please
yes,
continue.
sir. Basically, sir, the patient included when the trial is designed, they included the oral cavity also. Those who are not candidate for the surgery, those who are considered for the CTRT, but the number of population is very low in
Very
this
less.
this part, so this is not included in the final conclusion.
So
So oropharynx and hypopharynx is the final answer.
right. So in oropharynx, hypopharynx, and larynx, whatever the nivolumab plus cisplatin plus radiotherapy was given, And suppose and there is a residual disease in the neck and the primary is completely responded. So was surgery included in the planning, or it was done or not for the neck, like for the neck nodes, like neck dissection and anything in those
Yes,
cases?
sir, definitely, sir. So because, sir, there should be a at least some post-hoc analysis. There should be what happened to the patient, those who have a regular disease after that. Because when you see the last population overall survival, there is a 4 year survival almost more or less same. So
Mhm.
subsequent, they consider for the patient those who have a regular disease for a salvage surgery if possible for the patient, sir. But that is
And
not published anywhere, sir.
okay, any data on what was the morbidity of taking up patients for these patients for surgery, or any difficulty happened when surgery was done in
No, sir.
emergency?
That is the same
Any
as a,
data for that?
no, sir. That is same as a those patient received salvage surgery after definitive CTRT. This is more or less same in the both groups, sir. Nimotazumab
Any
doesn't add any specific morbidities for this patient. This is same as the same radiation also.
and these studies is specifically for HPV negative oropharyngeal cancers,
Yes, sir.
right?
Mostly this is
So
SPV
any
negative.
data in the world around for the HPV positive cases?
No, sir. No, sir. No, sir.
Not there.
The main concern is that actually also, sir. This study basically done in mainly basically two countries. One is Cuba, and because drug developer Cuba, and this is India. So Indian population mostly is P16 negative, and we didn't have so much facility. We should conclude all P16 positive analysis in all patients. So our mostly patient is P16 negative, and we didn't still have a facility to detect P16 in all cases. And pneumotozuma, one more concern is that pneumotozuma financial part is also mostly a concern because this show a good benefit in P16 negative oropharyngeal cancers, but still due to financial toxicity we cannot add on our all patients.
But the European data should be there because the oropharynx there is 90% they will be HPV positive there in comparison to India.
Yes, sir. Yes, sir.
But the Europeans probably are not very keen to kind of develop or promote this particular medicine, if I'm not wrong. So
Yes, sir.
this does pertain mainly to our Indian or this Cuban population only, if I'm not wrong.
Yes, sir.
Right. Thank you. Thank you very much.
Thank you so much, sir, for your expert comments. Thank you, Dr. Abhishek, again for
Yes, sir.
very lucid talk. And
Yes.
now for the next session on early breast cancer, we have none other than Dr. Dinesh Mangal, sir, a stalwart of his field and a renowned radiation oncologist at Manipal Hospital as a chairperson. He will be joined by Dr. Vijay Yadav, a very dear friend and a very senior oncosurgeon at Manipal Hospital. We also have with us Dr. Kapil Dev. He's a very good friend and a very excellent oncosurgeon. He's currently at HCG Hospital. I would request the chairpersons to kindly invite the speakers and take this session forward. Dr. Kapil, kindly.
Thank you, Dr. Lalit, uh, inviting me as a chairperson for this topic on breast cancer. So, should I start now?
Yeah, please, sir.
So the first speaker will be Dr. Ankush Rathi. He's director and
So for
consultant.
some reason, Dr. Ankush Rathi is currently not available, and Dr. Sarika Lamba will be presenting the first talk.
Okay.
You kindly invite her.
So, okay. So I'll invite Dr. Sarika Lama. She's a senior consultant, surgical oncologist, Santova Durlabji Hospital, Jaipur. And she will speak on no axillary surgery versus axillary sentinel lymph node biopsy in patients with early invasive breast cancer and breast conservative surgery. Final primary results of the intergroup Sentinel Mama trial. So please, Dr. Sarika Lama, you are most welcome.
Good evening, sir, and good evening, everyone. Thank you so much for inviting me in the talk. And actually, after reading all these trials, then you get to realize what treatment change you need to do in your patient. Because definitely, we have seen there are very few trials which are going for on the surgical side rather than in the medical oncology side. You have daily one or other trial coming up. So thank you so much for in advance for patients listening to me. Can I have my slides, please?
Ma'am, the slides are visible.
Yes, very much visible. So we are discussing with the no axillary surgery versus axillary sentinel lymph node biopsy in the patients with early invasive breast cancer in breast conserving surgery. Day by day, what we are seeing is we are now going more or more less aggressive. We are becoming more conservative in the management of all the type of cancer, and specifically the breast cancer in this case scenario. So we started with the radical mastectomy, we came down to the modified radical, then we came to the breast conserving surgery. Same thing happened in axillary surgeries, like from the axillary level 1, 2, 3 nodal dissection to axillary level 1, 2 dissection. Then came the sentinel node biopsy, and now after the ECOSOG Z11 trial, we came we cut down the axillary surgeries further, and now after this we came to with the sentinel node biopsies. And now from the sentinel node biopsies, so no axillary surgery versus sentinel node biopsy. So the role of surgeon is definitely day by day going down. So this is the trial, INSEMA trial. So we are discussing the final results of these trial. Can I have a next slide, please? Next slide, please. So the background of this trial was this is one of the 4 ongoing de-escalation trials which are evaluating complete omission of axillary surgery in the patients with the breast conserving surgery along with the INSEMA, along with the SOUND trial or a CINOMAC or a Nautilus trial. So this is one of the 4 ongoing trials. So the SOUND study, which showed that you can avoid the axillary procedure in the patient with a small breast cancer up to 2 centimeter, is not inferior to the sentinel lymph node biopsy. This was the conclusion of the SOUND trial. So we did the INSEMA trial, with the goal of which was basically to demonstrate the complete omission of axillary surgery. It is not inferior to the invasive disease-free survival as compared to the standard sentinel lymph node biopsy in early breast cancers with BCS. Next slide, please. So the primary objective, as we discussed, was to compare the invasive disease-free survival after BCS between the no axillary surgeries versus sentinel lymph node biopsy. So the eligible criteria, the inclusion criteria was like the age of more than 18 years, clinically T1, T2 disease with node negative status, and the patient was planned for the BCS and post-operative radiation therapy. So the number of candidates which were included, the participant, as per protocol, it was like 5,230. They were randomized in the ratio of 1:4. So no sentinel node biopsy has 1,046 patients versus the sentinel node biopsy, which was having a 4,184 patients. The secondary objective was to compare the invasive disease-free survival after BCS between the sentinel node biopsy alone and the completion ALND patients. So it was the patient recruitment started in the Germany and Austria in 2015 to 2019. Next slide, please. Next slide, please. So it was a non-inferiority trial, which was tested based on the confidence interval of the hazard ratio. That was to exclude the hazard ratio of 1.271 from the primary objective, and which correspond to the absolute decrease in 5-year invasive disease-free survival rate from 88% to 85%. So the criteria, the method which was used to adjust the hazard ratios for the stratification factors were like age, tumor size, the tumor grading. Next slide, please. Next slide, please. Yeah, so they calculated the sample size based on the events which will be happening. So when they adjusted 1:4 randomizations and 851 events and 4,230 per protocol patients were needed for the total first randomization. And they assume a 5% rate of the patient who have to be excluded from the analysis. So 5,505 patients were needed for the first randomization in this. And all the final efficacy was analyzed when there were 851 events for the first randomization, or the time-driven analysis was performed when there were after the 5.5 years, when the event rate was lower than the 851. Next slide, please. So that is what the design of the study was. They assessed for eligibility for the randomization. So they had 5,502 patients, in which there was a dropout rate of 348 patients dropped out. So the final patients were, the number of the patients were 5,154, in which they were 296 patients were also excluded because of 252 they were given with, without post-op radiotherapy, 38 had axillary surgery, which was not according to the randomized arm, and 6 because of the other. So the per protocol patients set was 4,858, in which they divided into the 1:4 arm. So the no sentinel node biopsy arm has 962 patients versus the sentinel node biopsy, which has 3,896 patients. So if you look at the data, so in those sentinel lymph node biopsy arms, so no sentinel node was detected in 38 patients. Sentinel node negative, which was 3,275. Micrometastasis was seen in 133 patients. 1 to 3 positive lymph nodes were seen in 438 patients, and more than 4 node positive were in the 8 patients. Next slide, please. So that basically corresponds to the 3.4% patients who are having a micrometastasis. 11.3% they were the 1 to 3 node positive, and more than less and 0.2% patients were having more than 4 nodes positive. Next slide, please. So the baseline characteristics which were seen, so the age was, they were divided into the less than 65 years versus more than 65 years of the age, and we can see in the both the arms the characteristics was almost the same. So the in the less than 65 years of the arm, the 10.8% patients were the less than 50 years of age. You see, as per the tumor size, as per the grading, you can see that most of the tumors were basically G2, grade 2 and grade 1 tumors. And 95.2% patients were HER2 positive and HR positive, hormone receptor positive, and HER2 negative subtype. We can very well see these are almost 98%, 98.4% versus 98.5%. Next slide, please. So the primary endpoint was, which was basically invasive disease-free survival event, and as per the per protocol analysis. So as we discussed that the hazard ratio lies below 1.271. So we can very well see that the two lines are not at all separating. There was a median follow-up of around 6.1 years. So we can very well see the survival rate is 91.7% to 91.9%. So this is basically, that shows that in the no sentinel lymph node biopsy is equally good to, it is not inferior to the sentinel node biopsy. Next slide, please. So the first invasive disease free survival event, the invasive locoregional recurrence. In overall patient, it was in overall 4,858 patients, it was basically 1.5%. That is in total in 72 patients. You see the axillary recurrence in the no sentinel lymph node biopsy arm is basically seen in the 10 patients, almost 1%, versus the sentinel node biopsy, which is 0.3%. Ipsilateral breast recurrence was invasive breast recurrence was seen in the 0.8 to 1.1%. Overall, when we see the invasive contralateral breast recurrence or the distant relapse and the secondary malignancies or the death rate, it was equivalent in both the arms. Next slide, please. So the overall survival, that also very well we can see there is no difference. Both the lines are continuing on the same side till age 6.1 years. So the survival remains the same in both the sides. Survival rate was the 5-year was 96.9% versus 98.2% in these patients. Next slide, please. So invasive disease-free survival in subgroup, you can see that this red line is basically that the hazard ratio of 1.271. So the longer invasive disease-free survival without sentinel node biopsy, and with the sentinels, we can see everything falling in the favor of with no sentinel lymph node biopsy. Next slide, please. So the conclusion was like In this INSEMA trial, which was enrolling the 5,500 patient, it significantly demonstrated that omitting the sentinel node biopsy in clinically node negative patients in the early breast cancer and which are scheduled for the breast conserving surgery did not result in inferior outcome. So they have a very good survival, 96.9 versus 98.2% that we saw just now. And so this de-escalation concept is suitable for the patients, those who are more than 50 years of age with grade 1, grade 2 tumors, hormone receptor positive and HER2 negative subtype, and a preoperative tumor size for up to around 2 centimeter. Next slide, please. So this is what is now included in the NCCN guidelines also, the latest version 6.2.24. So what they say, you do a sentinel, no palpable lymph node at the time of diagnosis, and limited axillary involvement, which is confirmed on the needle biopsy and the imaging. So we do a sentinel lymph node mapping and excision. If the sentinel lymph node is not identified, then you do a axillary lymph node dissection in level 1 or 2. You find the sentinel node negative, normally we do not do further surgery, but if it is a positive sentinel node and we are doing a breast conserving surgery and we are meeting all the criteria, that is clinically T1, T2, N0 disease, no preoperative therapy, or 1 or 2 positive nodes are in the sentinel node biopsy, and we are planning a whole breast radiation. If all the criteria are followed, still we do not need a further axillary surgery. This is the impact of these 4 de-escalating trial on these NCCN guidelines. If definitely we are not meeting all the 4 criteria, so we have to go with a lymph nodal dissection in the level 1 or 2. Same cheese happens if we are doing a mastectomy also. If we are finding a micrometastasis in sentinel node, we are not doing any further axillary surgery. And if we are not meeting all these criteria, then we do a axillary level lymph node dissection of level 1 and 2. Right. Next slide, please. Thank you so much. And so definitely my take on this trial is basically we are continuously evolving, and we are going for a less invasive procedure, less defiguring procedure in the breast cancer. And it is definitely better. We are avoiding axillary surgeries nowadays, unnecessary lymph nodal dissection. When we started doing only level 1 and level 2 node, we were very much able to control the lymphedema part. Yes, we are still seeing the lymphedema in the patients, but because we are going intravenous, we are not removing the sheath, we are not doing a level 3 nodes, definitely the chances, the occurrence of lymphedema has reduced. Same thing, then we went for the sentinel node biopsy. So we were able to reduce the incidences of seroma and the paresthesia and the lymphedema. And now with these trials which are coming up and which are showing that less and less is more in the breast patients to give them a good quality of life, it is definitely advisable to, and this is what we are doing nowadays. I have done 2 or 3 patients in my in my setup now recently only, with the patients with the breast conserving surgery planned. On imaging, they were found node negative. We did a low axillary sampling because unfortunately we do not have a Kama camera at our setup. We are having it soon now. So we did a axillary node sampling and sent it for a frozen. We have a very good frozen facility available, and we can very well trust our pathologists. When they said that it's all negative, we did not do any axillary surgery further. So definitely it is going to be a change maker in the management of a breast cancer. Thank you so much.
Thank you so much, Dr. Sarika, for that wonderful talk. And I believe we are trying to make the surgeries as less radical as possible. And this seems the effect of these changes does see in the post-op morbidity of these patients, now that we are finding lesser patients having those morbid lymphedemas now. And may I thank you so much again for that wonderful talk. May I ask Dr. Kapil to kindly give his pearl of wisdom and take the session forward?
Good evening to all of my teachers and Thank you, Dr. Lalit, for the. Actually, I am saying that in these kind of patients in our practice, very difficult to get these kind of patients. Only in that study, they are found only less than 10% patients are patients in node positive. But in our practice, only 10% patients are found that node negative patients. So, although it is very good thing to preserve the axilla and avoid the complication of axillary surgery, but in very selected patient we can do this. Thank you
Yeah.
so. I would like to.
Dr. Kapil, I have just one say in that. There is another trial, which is a de-escalating trial, which is a Nautilus trial, which is still recruiting the patients. It's basically for the Asian population, premenopausal females, which are normally having the higher tumor burden, and they are at a younger age group and more premenopausals, and basically the Asian population. So they are still recruiting the patient, and we are eagerly waiting for that Nautilus trial result. Basically, a Korean group which is doing this trial. So yes, definitely there is a difference between the European and the Asian population, and the breast cancer genetics in both is different. But that's what we are looking forward is with basically with the Nautilus trials, what the result will be coming.
So I would like to invite the next speaker, Dr. Rahul. I think from
Dr. Rahul
Apex
Yadav.
Hospital. Dr. Rahul is login.
Yeah, he was there. I
Yes.
could see.
Yeah.
So I'd like to Dr. Rahul for the speak about axillary management, when to dissect and when to radiate. So please welcome.
Hello. Thank you. Thank you everyone for inviting me here. And I am Dr. Rahul, surgical oncologist at Apex Hospital, Jaipur. So when we can start, let's have the slide if anybody can put the slides on. Slides, please.
Tech support, can you please pitch in? And yeah.
So as last speaker was also saying that surgical management is getting changed. It's started from very ultra radical to radical and now conservative. And starting slide, please. Sorry. So no, start from this one. Okay. So now the time has come when we are very comfortable with the conservative surgeries for the primary disease. The breast conservation has become a norm in some way, but the axillary dissection still has a problem. A lot of problems are there. A lot of situations arise when to do axillary lymph node dissection, when to do sentinel lymph node biopsy, what to do in the situations where clinical node positive patient turns node negative after new adjuvant therapies. So all these situations we will like to address today in this topic, and hopefully you will be less confused after this uh, topic. But it is a cumbersome one. I will try to accumulate it in the slides which are present as much as possible. Next slide, please. So all started from NSABP 04 trial, where axillary lymph node dissection was compared directly to radiation. Mastectomy was the main arm, but axillary lymph node dissection was also compared in this trial. And now we have moved after that from the eras where Milan trial was done for sentinel lymph node biopsies in N0, and ACOZ trial, Sentina, SNFNC, where even the positive nodes were left, and Ambrose trial where RT was used as a substitute for axillary lymph node dissection. Now has the time come for Natalie trial and the trial previously discussed, where we want to do sentinel lymph node biopsy or not? That is the question now arising. So next slide, please. Next slide. Next slide. So what is the main point here is that no randomized trial till now has shown ever a disease-free survival benefit or overall survival advantage. Either you do an axillary lymph node dissection or a radiation has been used for axillary management. No benefit has been there in either of the arms. And isolated axillary recurrences after either a sentinel lymph node biopsy or a lymph node dissection or RT has been a rare event. So this question arises that we need to go that radical and do lymph node dissections, complete level 3 up in all the cases, or when to leave only at sentinel lymph node biopsy, and what to do in the cases where even 2 or 3 lymph nodes are positive, what to do in these cases. So next slide, we'll start from the cases where clinically patient is N0, node is negative. And for this, we have different trials for N0 specifically, which addressed in the cases like Z001 trial or AMROS trial. And in these trials, different first question was addressed, either use a sentinel lymph node biopsy or go to ALND. And subsequently, we reached a stage where we want to ask the questions where if sentinel lymph node biopsy is also needed or not. Next slide. So what happened in NSCBP04 is that early stage operable cancers were taken and it were divided between radical mastectomy and total mastectomy or with radiation, or total mastectomy alone. And if you see at the trial, next slide, if you will see the arm of the trials, the axillary management was done in cases of radical mastectomy. You have to do a lymph node dissection, and ALND was done. Total mastectomy in cases radiation was given, so the axilla was also radiated. And single total mastectomy arm, there was no surgery was done for axilla. So node positivity was nearly similar in all the arms. Next, but when now you will see the difference that in axillary lymph node dissection and RT, no survival advantage was there in either arm. But next slide. But there was 17% when you didn't use any of them, either axillary lymph node dissection or either radiation, neither was used. Then there was a 17% chances of axillary relapse was there in the cases when axilla was not addressed. So it became a norm that either you have to do a axillary lymph node dissection, and axillary lymph node dissection itself was become a norm, or subsequently we use sentinel lymph node biopsy also. But radiation was also seen that we can, in some cases where risk is less, and we can use radiation as another option. Next. In one other point was there that why axillary lymph node dissection was done, because in early trials, in most of the early trials, what happened that they needed axillary lymph node dissection for complete nodal staging. Sentinel lymph node biopsy has not become a norm till this 90s and Milan trial. So most of the initial trials used only axillary lymph node dissection for complete nodal staging. Next. After Milan trial, as I told, clinically N0 negative sentinel lymph node biopsy, no survival advantage was found for this axillary lymph node dissection, and node positivity was also very less. So it became a norm that sentinel lymph node biopsy should be done in clinically N0 patients. Next. So as I have mentioned previously also, Milan trial was the pivot point after which it all changed. So Milan trial, what they did, that they took very early cases, less than 2 centimeter cases, treated it with BCS, sentinel lymph node biopsy was done, or axillary lymph node dissection was done. If you see at false negative rate, it was around 8%, and there was no difference in overall survival or disease-free survival, and axillary recurrences were also very less in both arms. But still, there was a contraindications. But because some people said that it is only for early stage cancers, less than 2 centimeter tumor is there. NSCBP 32 trial B32 nearly removed all those, because in this the size constraint was also removed. Both BCS and mastectomy patients were taken into consideration, and axillary lymph node dissection and sentinel lymph node biopsy was compared head on. and it was found that still no difference in 10-year local regional recurrence and disease-free survival, and axillary recurrence is still very less in both arms. Next. And a last point also I left that only in more than 60% of the cases you found that only node positive is the sentinel node positive. That became the pivot of uh, finding that even one node is identified and that it is negative, then it can also lead to identification of a negative axilla. So after that, what came an era where you find that you start finding micrometastasis in some sentinel lymph node biopsies or single node positive in sentinel lymph node biopsies. For that, we had Sinomic trial, AMROS. So all these uh, uh, address that issue in which if either limited metastasis are there, what need to be done and what need not need to be done. Next. Uh, Next. So what happened in Z0011 trial also that uh, in sentinel lymph node biopsy alone, even and axillary lymph node dissection, you found that only 1% non-significant difference was there. It was in the cases where even a single node was positive. Then only axillary lymph node dissection was not done even after that. Then no significant change in the positive recurrence rate was found at 10 years also. Next, disease-free survival and overall survival was nearly also similar. In AMROS, you um, head-on axillary lymph node dissection was compared with axillary radiotherapy after sentinel lymph node biopsy. Even if it was positive, cases were included and only axillary lymph node radiation was given, and still the same results. Only nearly 1% difference was there in axillary recurrence, which was non-significant, and overall survival and disease-free survival was similar even after 10 years. Next. So what you can see, most of the trials, even micrometastatic disease, macrometastatic disease in recent trials like Sinomec also, what they found is that very slight axillary recurrence difference of 1% non-significant difference was there. And if you go to overall survival rates, there was not any significant difference in any of the arms. Next. So in clinical N0 neck, tumor size also, like you see in Sinomec trial, even up to 10 per centimeter tumors were taken, and head-on sentinel lymph node biopsy axillary radiotherapy was compared with axillary lymph node dissection, and no difference was there. Next, even the number of sentinel lymph node dissected was compared. Even the number has been in some cases up to 4, sometimes up to only single node in some trials have been taken in consideration, but no difference was found ultimately. Next. Next. So it took us to a time where we have completely decided that N0 um, axilla is there, then sentinel lymph node biopsy is nearly enough. And if sentinel lymph node biopsy comes positive, and then also we can omit axillary lymph node dissection in most of the cases, but we will still left with some controversies like if T3 more than 5 centimeter tumor is there, T3N0 patients are there, and 1 to 2 sentinel lymph nodes are positive, or if mastectomy has been done in clinically N0 negative patients and then sentinel lymph node have come positive, if you have dissected more than 3 sentinel lymph nodes and 3 nodes have been come positive, and what is the status of axillary lymph node dissection to determine eligibility for adjuvant endocrine therapies and systemic therapies. Next. So all these controversies have been addressed in different trials. Previous one, please. Yeah. So uh, like in this, if T3 tumors are there, whatever the trials I have shown in the last slides, only one Sinomec trial took a size more than 5 centimeter. They have taken up to 10 centimeters. So only one trial addresses that concept where T3 tumors have been taken. So data is not there where we can say confidently if higher risk of metastasis is there and higher risk of axillary positivity is there. So what we should do when one or two lymph node is positive. Next slide, please. So what is there in Sinomec trial was that clinically T1 to T3 tumors were taken and BCS or mastectomy was done, and 1 to 2 macrometastasis was found on sentinel lymph node biopsies. So these patients have been divided into two groups: either sentinel lymph node biopsy alone with nodal irradiation, or axillary lymph node dissection plus nodal irradiation as per guidelines if required. And it was compared for primary endpoint of overall survival and secondary endpoints of recurrence-free survival. Next.
Phil, please give a little bit fast. Conclude it. No? So there is time constraints. Please.
Yes, next slide. So there was no difference found in 5 years relapse-free survival in these patients, and it was found that even T3 tumors is there. So sentinel lymph node biopsy and axillary lymph node dissection with radiation has no significant difference. Next. So next. So as I told that there was no significant difference was found. Only in the cases of extracapsular extension cases, there was slightly increased chances. Otherwise, there was no benefit was found. Hazard ratio was little. So next, in the cases of N0 mastectomy population also, next. 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 Next, please. Next. So in these cases also, like in AMROS or Watersort trial, mastectomy patients were direct mastectomy trials are not there. Mastectomy patients are present in previous trials, Sinomec and this Watersort trials. And there was 36% patients were there in which axillary lymph node dissection was compared with axillary radiotherapy. Next. So in this also, what they found that in cases of mastectomy, this with 1 to 2 sentinel lymph node positivity, macrometastasis, axillary RT was recommended to provide effective local control. Next. 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 You can skip that. Next. Next. So in this next. Similarly, in N0, for exactly 3 positive lymph nodes, also there is not enough evidence to make recommendations, and still we are proceeding with axillary lymph node dissection and considering this loco-regional irradiation also after that. Next. And this subgroup actually is very rare that when you do a sentinel lymph node dissection and you found all the 3 lymph nodes positive, and clearly in West, axillary lymph node dissection, even in these cases, have been started to omit, and it has increased from 29% to 41% in many databases. But in our cases, we clearly go for axillary lymph node dissection in these patients. Next slide. But in West, what they are doing is that even in such positivity rate, even 3 lymph nodes are positive, they are trying to omit, and they are trying to find out evidence for these cases where there no benefit is found. Next. On this previous speaker has also talked about this INSEMA trial. In subgroup analysis in this trial, subgroup analysis in the cases where 1 to 3 lymph nodes are positive, these are further randomized for sentinel lymph node biopsy alone and axillary lymph node dissection. So when this trial result, next. comes, we will have more data to identify that 3 lymph node are positive, that either we can go for sentinel lymph node biopsy alone, or we can go for axillary lymph node dissection. For now, the data we have, we can only say that we are still proceeding for axillary lymph node dissection in such cases if 3 lymph nodes are positive. Next we can skip that. Is just, we are in these slides, we are trying to compare that if uh, hormone receptor positive tumors are there, so what is the status of, if axillary lymph node dissection is required after sentinel lymph node biopsy, positivity rate for inclusion criterias of monarch trial eligibility criteria, which needs more than 4 lymph node positives for the cases where you want to give PARP adjuvant therapies and other adjuvant treatments. So if you want to go in some cases where 1 or 2 lymph node is positive, you want to further go for axillary lymph node dissection, or sentinel lymph node biopsy alone is enough for this uh, positivity to identify further cases who can be eligible for monarch trial inclusion. Uh, Next. But in these cases, most of the trials, they have found that in such patients, either you want to find out this inclusions in this Olympia or Monarch trials, axillary lymph node dissection does a lot of harm. It has made around 20% of physical impairment in the patients where it was done after initial sentinel lymph node biopsy. More lymphedema was present and more physical impairment of the arm was found in these cases. Next. So this is the summary that omission of axillary lymph node dissection for axillary radiotherapy is oncologically safe in T1 to T3 N0 trials undergoing either breast conservation or mastectomy. Mastectomy patients also with micromets needs no treatment further. 1 to 2 sentinel lymph node positive with mastectomy needs primary radiotherapy and axillary radiotherapy also, post mastectomy radiotherapy plus axillary radiotherapy also. Next. For 3 lymph nodes or 3+ lymph nodes, axillary radiotherapy should be included. Data is evolving for further dissection or not. In the settings of sentinel lymph node positive disease, it is not advised for further dissection, just to identify eligibility for systemic therapies like CDK4 and CDK6, and sentinel lymph node only is enough. Next. N0 we can skip and we can go in the last slide. Skip further. Skip. Yeah, I am
Rahul, if you
concluding. Yeah,
can we
yeah,
take this?
Rahul, please conclude.
yeah, I'm concluding on last slide. Sorry.
Please. Thank you.
Concluding on last slide. Yeah. Stop on conclusions of N positive. Yeah. Next. Yeah. So N positive also, and node positive population also. Last slide, please.
Previous one.
Please, previous slide, please. So N positive nodes also. Sorry, can you keep on that slide?
The summary one.
Yeah, this one. So N positive population also, there is a issue that when after adjuvant therapy, if node becomes negative, you have a YP N0 node, then axillary lymph node dissection is not required, and we can go only for sentinel lymph node biopsies in the patient who have converted after NAC, and radiation also is not. Data is evolving that you can avoid regional nodal radiation also if you find sentinel lymph node biopsy negative also. If you find similar cases with residual isolated tumor cells or micrometastasis, radiation role is still unclear and data is not there to either to either refute the claim or support it. In the cases where node is positive after sentinel lymph node biopsy, axillary radiotherapy can be used in lieu of axillary lymph node dissection also in the N1 patient where residual nodal disease is present post NACT in sentinel lymph node biopsy. So this is a summary. There are different trials to support it, alliance trial and all. Sorry for the time, but it was a long topic, and I thank you all for patiently listening. That's it.
Thank you, Dr. Rahul.
Thank you.
Thank you, Dr. Rahul, for agreeing to present it at such a short notice. Thanks
sir.
again.
Sorry, sir.
Dr. Uttam Soni, yes, you want
Sir,
some...
good evening. Can we ask a question?
Yes,
Dr.
sir.
Rahul?
Yes, sir. Yes, sir. Yes, sir. Absolutely.
Rahul, it was a wonderful talk, wonderful talk from your side. I know it is very difficult to present these things in such a short span of time period. But
yes,
my question is, so whatever trials we have seen, what you have presented, they all say that if you have lymph nodes positive, then you can leave the axilla. Now, what does leaving the axilla means? But the axilla needs to be addressed in some manner or other, isn't it?
Sir, sentinel lymph node biopsy has been done.
You got, say you got 2 out of 4 nodes. Now what?
Yeah, now data is evolving that 2 nodes are positive. You can leave in the cases of BCS, and even in mastectomy cases also. I've shown the trial. Now the data is evolving that patient is getting radiation in the cases of BCS, and in the mastectomy cases also data is there that axillary recurrences are not that much. You can leave after 2 lymph node positive in the cases sentinel lymph node biopsy has been done, and you don't need to go for ALND in all these cases.
So my question to you is not what data is saying. I'm saying how ready are we to accept the data in Indian settings? Now, if you as a surgical oncologist get 2 out of 4 nodes positive on sentinel lymph node biopsy, would you leave the axilla or would you address the axilla?
Currently, as per my practice, I am addressing it. But in the case, what we are trying to convey is the new data which is coming up, that in the cases where hormone positivity is there, less radical surgeries has been done and radiation has been used as a adjuvant treatment, we can avoid going further. And if single node or 2 nodes are positive, even in the some cases I have shown 3 lymph nodes are positive, people are leaving now, and omissions of axillary lymph node dissection is taking further and further steps. We might not be ready, but data is coming from West world a lot, and now we can think in this direction.
So that data actually says and suggests that if you are not operating on that patient, you need to address the axilla with radiotherapy.
Yes, absolutely.
And addressing the axilla with radiotherapy is again a disaster.
I think radiation
I'm just trying to create a controversy what you have said, but that's how it is in clinical practice, isn't it?
No, sir, I don't think radiation oncologists.
We can take this up during the panel discussion.
Yes,
Rahul is also on the panel with you, and we'll have a very renowned radiation oncologist along with the other renowned surgeons, pathologists, and radiologists on the panel.
Yes, sir.
So, Dr. Uttam Soni, sir, could you please kindly go ahead with the panel?
Can I start with it? Okay, great. I'm sharing my screen.
So while we are setting this up, let me invite the panelists. In the panel, we have Dr. Nitin Kuteta, sir, a very renowned surgical oncologist at Mahatma Gandhi Hospital. Dr. Sarika Lama, senior consultant surgical oncologist at SDMH. Dr. Rahul Yadav, surgical oncologist at Apex Hospital. Dr. Manish Chomal, senior consultant and head radiation oncology at Renova Cancer Center. Dr. Abhilasha Maan, consultant radiation oncologist at Manipal Hospital, Jaipur. Dr. Manoj Kumar, he's a senior consultant radiologist and HOD at the Department of Radiology, Manipal Hospital. And Dr. Arundhati Kelkar, she's a senior consultant oncopathologist at Precision Path Labs, Jaipur.
So I have a very, very esteemed panel with me, very learned panel with me. And my job today is, again, as I was telling Rahul also, is to create some controversies. I'm not going to discuss. We're going to have SABCS panel on here, but in the meantime, we'll try to make some more practice changing things or what we are practicing right now. So the purpose is to improve on the clinical practice. Shall we start straight away? We have all the panelists on board.
Yes, Uttam, please start.
Okay, sir. Thank you. So I will start with the case straight away. I have a 45-year-old female. She has a normal menstrual history, family complete with 2 male children. The elder one is 25, the younger one is 21. No medical history. She complains of a left breast lump for 2 weeks. On examination, there is a 1.5 into 1.5 centimeter hard, irregular mobile lump in upper outer quadrant. Axilla is absolutely normal on clinical examination. My question goes to Sarika. Sarika, how do we proceed further from here?
Sir, looking at the clinical staging of the patient, the first and most important thing, I'm not saying that it's a cancer. The first thing is to investigate further to prove it is a cancer. So at the age of 45 years, we basically perform a mammosonograph. That includes axillary imaging also. And once the mammogram or the ultrasound suggests us it to be a Birat's category 4, 5, we do a tissue diagnosis with it. And then we further proceed according to the mammogram and the biopsy report.
Okay. Dr. Manoj, do you agree with what Sarika is saying? She is saying we need to do some radiological tests and mammography and supplemented by an ultrasound of the breast and of the axilla. Do you agree with that?
Yeah.
Okay, fair enough. So we did that. Mammography showed a single M5 lesion in upper outer quadrant. USG supplemented that it was a single U5 lesion, 2 o'clock. Axilla was absolutely normal on ultrasound, and we did an ultrasound guided through-cut biopsy. It showed an IDC grade 2, hormone receptor positive, HER2 negative, Ki67 of 20%. Dr. Arundhati, she's there? Is she around?
Yes, sir. Yeah, I'm here.
Okay, Dr. Arundhati, so is there anything else that we need to do on this two-cut biopsy? Is there any information which is missing?
As of now, sir, this information seems complete.
Okay. And do you think Ki67 is important in this patient?
Yes. Ki67 is it's virtually at a cutoff of 20%. That helps us to differentiate between high risk and low risk. So anything below 20% is considered as a lower risk. So yes, Ki67 is important.
All right. So the point to raise or the point to highlight here is while we are doing an ISC on any breast tumor, we should have a Ki67 handy with us because that surrogately actually gives us an idea of a high-risk cancer. Dr. Manoj, what about an ultrasound guided through-cut biopsy? Do you always do it guided or a blind biopsy is also okay?
No, we always do ultrasound guided, image guided. Because many times, associated cyst may be there surrounding the lesion and you can have a negative biopsy. So always it's better to go under the guidance of imaging.
All right. Fair enough. I think that is very important. And what about the importance of an FNAC?
FNAC sometimes may be difficult for pathologists to interpret it many times because of hemorrhagic component. Biopsy is also, in terms of invasiveness, if you say, we just use this little, very small needle that is equal to FNAC in terms of invasiveness. And why FNA? I don't see any, because many times it turn out to be a negative. Then again, there is high chance to get it repeat for the biopsy.
So what we want to highlight is FNA is a quick method, but a more reliable method now in this current era is true cut biopsy, which needs to be done all the time guided, which gives us a more broad information about the tumor, forms sort of a horoscope of the tumor, and help us in planning the treatment in a better manner. I hope everybody agrees with that.
Also, sir, FNA is not going to give you material for testing for hormone receptors and HER2 and Ki67. So it's also always better to have a tissue diagnosis as compared to FNAC.
So Arundhati, I will not agree here. A properly done FNAs B can actually give you enough material to formulate material for forming a block. But
yes,
again,
yes,
a true cut is always easy, better. You don't have to struggle with that.
Same thing can happen, Uttam, can I speak something?
Are Bossy, you are always welcome.
Thank you. So, like, having an USG is the advantage of USG that you can screen the axilla also simultaneously. And if you find suspicious node, you can do an FNAC from the axilla, or if you can do a true cut biopsy or plan for neoadjuvant protocol, you can put a microclip there for further TAT dissections and all. That's the advantage of USG guided true cut biopsy.
So I am doing all my biopsies on my own. And what I have actually learned over these years is when you're doing it in a blind form, you're doing it blindly, you tend to move more in the periphery. And in the periphery, you can have more reactive tissue rather than the tumor itself. The second thing is there are many tumors which have central necrosis into them. And if you are into the center of the tumor without any guidance, you probably might just land up with necrotic tissue. If you're doing it under USG guided, you can actually guide your needle through the area wherein you need to have proper tissue of the tumor itself, live tissue. That's what, So guided is always better. Yes, axilla can be done at that time. If we see any suspicious node, we can FNA or we can do a true cut biopsy of the node as well. So we did all this. We have all these results. Now what? Dr. Nitin Kuteta, boss. Kuteta, boss, you there?
Doctor, let me put one question now. That suppose the FNAC is negative, the patient sometimes may not agree for the biopsy.
Sorry?
In that case, the FNAC is negative. We need to discuss with the patient that the clinically and radiologically it appears to be a high grade. It may be a malignant, the chances are very high. So we need to counsel the patient that we need to have biopsy to confirm or not to confirm that it is malignant or not. And it's a must to do.
What next? Kuteta boss, how to proceed further after this?
I think we have done all the workup in this case, chest X-ray, ultrasound, abdomen, blood biochemistry, stage the disease properly. It's an early stage cancer, right? And then we discuss with our multimodality, tumor board discussion with along other colleagues, and simultaneously discuss the protocol of treatment, plan the protocol of treatment, and discuss the protocol of treatment with the patient.
All right. What is the role of PET-CT in this case?
2 centimeter lesions with no other symptoms and clinically no the signs of metastasis. I don't think so. There's any role of PET scan in this case. Or if the blood biochemistry shows something like raised alkaline phosphatase or calcium levels and all, then only the indication of PET scan should be there.
Sarika, do you agree?
Absolutely agree with Kuteta, sir. There is no role of doing a PET scan in an early stage disease. And as correctly said by the Nitin sir, if we find something abnormal on the ultrasound imaging or the bone, raised alkaline phosphatase, then only we proceed for that. Else, no, sir.
In the present scenario, the most important indication is the patient is asking for a PET scan when they come for any lesion in the breast.
That is the most important case. That has become the most important indication nowadays for the PET scan.
Exactly. 100 out of 100 patients will come out, Doc साहब सिर से लेके पांव तक का पूरा body का एक scan करा दीजिए ना please. So we did that. Patient was asking for it. We did it. And it shows a single FDG avid lesion in left breast, upper outer quadrant. Now, PET shows few FDG avid axillary lymph nodes. So, what to do now? Sarika.
Here comes a catch. The clinically node negative axilla ultrasound is giving a node axillary negative axilla. Now the PET is saying that there is a FDG avid axillary node. Will definitely discuss with my medical oncologist colleague, because nowadays what they are trying to do is push the patient more for the neoadjuvant treatment and then go with the surgery. But being a hormone receptor positive, would suggest to do a FNA at least for this axillary node, guided FNAC with this axillary lymph node, if it is amenable for FNA.
Nitin Boss, do you agree with that?
Yeah, 100%. I think we need to know how much is the axillary lymph node burden on FDG it is there. So if it is there, which is significant, discuss with our nuclear medicine expert, then I think we should do an FNAC and prove it is metastatic or not, because this is going to change the treatment protocol of this patient.
Rahul?
Same situation, sir. If FNAC possible, we'll try once. Otherwise, go for the surgery and do a axillary descending lymph node biopsy and frozen section on table.
So the axilla earlier was normal on ultrasound. Ultrasound didn't show anything which is abnormal. Structure-wise, all the nodes are normal, I
want to say something, sir.
Yes, Rahul.
Sono is not the reliable modality for suspicion of lymph node. Yeah, there are certain criteria, just like we say, if there is loss of hilum, if there is eccentric cortical thickening, then there is suspicion. But many times it is unreliable also. So we should not rely much on ultrasound if especially if the size of the lymph node is normal.
So, in this case, as you said, the clear criteria for lymph nodes to be metastatic ultrasound, so mostly an operator-dependent, modality. So we need to correlate between the clinical, radiological, both aspects together to come to any conclusion and prove it cytologically or pathologically that the axilla is not involved by the metastasis.
So my question was, so I think I could not express myself very well. My question was, an ultrasound earlier done was showing normal axillary lymph nodes. A PET scan shows few FDG avid axillary lymph nodes. We are discussing about doing a guided FNA on these nodes. Where will the guide go? Because ultrasound, which is going to guide us, shows the lymph nodes are normal.
That's what I said, because we need to discuss with our nuclear medicine expert that these nodes which are FDG avid, are they looking metastatic? Because they can tell us exactly it's an inflammatory node or a metastatic probability is there in that.
I think that is a very valid statement. A constant conversation between you and your partner in the tumor board or your team should always be there, who's going to guide you through that. These FDG avid axillary lymph nodes in Indian situation can always be something reactive, and we need not worry too much about it. But at the same time, we need to keep into our mind that this axilla needs to be specially catered for, and we need to just take care of it while we are operating or we are treating this patient. What next now? What do we do after this? Nitin Boss.
So what is the decision of protocol made by the tumor board? We need to follow that.
So we are sitting in a tumor board right now. We got 3 surgical oncologists, we have got pathologists, we have got medical oncologists, and then we have radiologists and radiation oncologists. So okay, let's decide.
So the plan should be what? Now, what is the decision of the tumor board? You're the moderator. Tell the decision.
The lead is always the surgeon in the tumor board.
Surgeons are more, so I think, sir, we should proceed for surgery.
Nitin Boss is senior most. Nitin Boss, chalo please, batao.
So ERPR positive, HER2 negative, 2 centimeter lesion, no axillary nodes. Can we conclude on that? I mean, that's the diagnosis we have now.
Yes.
So go for surgery first and followed by adjuvant treatment, depending on the final histopathology report.
All right. So surgery follows by adjuvant treatment. What surgery will you prefer in this lady?
So we need to discuss with the patient in detail about the modalities that we have. Both modalities for this patient. We can go for mastectomy. Breast is concerned, mastectomy versus BCS. BCT we need to discuss with this lady, because if she goes for BCS, she has to go for radiotherapy, right? And
Yes.
depending on the final lymph node status, also we may have to, if she goes for mastectomy, we may have to add for radiation therapy if the lymph nodes burden is more in that case. As far as XLI is concerned, now we have to discuss about the sentinel node biopsy in this case and take a call on that.
Everybody agree?
Yes, sir.
So anything from the radiologist or radiation oncologist, anything else that we need to do, sir?
Sir, sorry to interrupt. Can we please conclude the discussion in next 5 minutes?
अरे पैनल डिस्कशन को 10-15 मिनट में कैसे खत्म करोगे तुम? ठीक है we understand your problems, Sarangi. We'll do that. We guys are also okay with that, isn't it?
Yeah, definitely.
So go for the very first BCS.
So Uttam, I want to ask you one question here. Like for all the panelists sitting here, that do you practice a peritumoral lidocaine infiltration as the trial was from Dr. Badwe at Tata Hospital, having a survival benefit in these patients?
This was a very well appreciated trial, say 2 years ago. I did it in a few patients, but I'm very lazy. So not doing in all of them, but I did it when it was very showcased. So initially I did it, yes.
Sir, I also did in few cases when I spoke to Badwe sir and we were discussing this trial. So I also started doing in this, but as correctly said, those 3 or 4 patients we did it, and afterwards definitely lost all that, and still I'm actually not doing it right now.
So
we are doing in all the cases where we are not giving Nugent chemotherapy. We are doing in all the cases peritumoral infiltration of lidocaine.
Great. The trial itself looked very nice, but I think probably now even Tata people are not doing it on a regular basis. Even they are not doing it. It is so surgeons, I think all of us has that instinct. If something clicks to us, we just accept it straight away, like how robotics or laparoscopic surgery is done. This is something which can be, I'm not doing it. I'm not doing it. Answer is this. So yes, we did BCS with sentinel lymph node biopsy in this patient. We did it with methylene blue, and we had a 1.1 into 1 centimeter tumor. All margins were negative. IDC grade 2. We had 4 sentinel lymph nodes. 1 was positive. What next?
Can I intervene, sir?
Yes, please.
So we did BCS.
We did BCS, yes.
Yeah. Without going MRI, suppose there is focal non-mass form of disease in similar breast or else in other breast, which is not picked up by the PET-CT.
Very nicely done ultrasound can always be replacing an MRI in these patients.
Never ever, sir. Because
yes, it
is.
It is a German study, the German study from I think 98 or say 98. It showed that when you do MRI on these patients who are undergoing BCS, you end up landing with doing unnecessary procedures in more than 30% of these patients. So
Sir, but whenever we are talking about the personalized medicine,
a patient who has more fibrous or dense breast, obviously, yes, an MRI is always welcome, but the patient with fatty breast, less of fibrous tissue or glandular tissue, a good ultrasound can always be okay.
And there is enough
sir,
many
time I just want to share one thing. Many times there is only a perilesional ductal extension of disease.
Oh yes, a mammogram will tell us. A mammogram will tell us.
No. Most of the time, non-mass form of the disease extension, we cannot visualize on a mammography. No, we cannot visualize on the sonography. Definitely not.
I agree with your statement, but DCIS or DIC, we can say that intraductal carcinomatosis that happens. But there's a lot of data now which shows very clearly there is no role of MRI in even you do a BCS, as Uttam has already, except in the cases where the breast is very much dense. Otherwise, there is no rule in that. There's enough data now for not doing MRI scan. And the results.
I just want to know the practice. Basically, we are not using MRI for every BCS cases, right, sir?
Previously, I was doing MRI scan in these cases where I was planning BCS, but now I'm not, because we have enough data in the world not to do MRI scan and adding the cost to the patient and adding the further more procedures in these patients unnecessarily.
Fair enough, sir.
Thank
So
you.
one more important thing was all the patients with NACT, they were supposed to get an MRI done pre and mid cycle, but now we are not doing it. We are just supplementing it with good mammograms and ultrasound.
Agreed with that. Agreed with that.
So BCS with sentinel lymph node biopsy was done, 1.1 into 1 centimeter tumor, all margins negative, IDC grade 2, 1 out of 4 sentinel lymph nodes positive. What next? Sarika?
Oh, discuss with medical oncologist, will not do any further surgery for the patient. And definitely the patient, since we have done the BCS, the patient will be going for the radiation therapy. We'll discuss with the medical oncologist how they plan to proceed, whether they want to go with the can assist or some prognostic markers to go ahead with it, or they will be giving a chemotherapy further. But no more surgery, sir, from my side, the patient.
अच्छा, तो let's see Sarika, your medical oncologist है कि सारिका तुम सोच लो कैन असिस्ट कराना है कि नहीं कराना है.
I'm definitely going to go with the can assist, sir. If the one node positive, even though Ki67 is at 20%, we'll still go with the can assist in this patient. Because this is receptor positive early stage disease.
One node positive, you will still do a
yes, sir.
can
We'll still do with the can assist.
in a 45-year-old menstruating
Yes, sir.
lady.
Yes, sir.
Your can assist score is low. Now what?
Patient will go with the radiation therapy and the hormonal treatment with that.
Okay, you will not advise this patient chemotherapy.
No, sir. If the can assist score is low, then
because
this is what we are actually doing since last 4 or 5 years.
With one node positive?
Yes, sir. With one node positive also.
N1 disease? Okay, fair enough. I think can assist is right now, they've shown up their results in Indian population in N0 better than N1. But
Yes.
I perhaps, I will not do it. I'll take it with a pinch of salt, and an N1 lesion, I'll just insist to have chemotherapy.
we have in panel medical oncologist also sitting. We can discuss with them about this situation now.
Where is the medical oncologist? I don't see him.
Lalit Mohan Sharma sir with us.
Lalit, yes, Lalit, you are there. Sorry, Lalit. A medical oncologist is the convener. ये lunch ही नहीं देगा अपने को कभी भी.
So we have two medical oncologists, in fact, sitting here.
Yeah.
I'm so
I
sorry.
was feeling more of surgical discussions in a surgical pattern. So we kept quiet that let us learn from the surgeons what you say.
So now you teach us.
We don't leave you. Don't worry. We don't leave you. Lalit boss, you are there. Both Lalit are there here now.
So what will you guys do with 1 out of 4 sentinel lymph nodes for a 45-year-old menstruating lady, Ki67 20%, HR positive, HER2 negative?
I think adjuvant chemotherapy in this patient after discussing well, and we will go for the ovarian function suppression or plus minus oophorectomy, whatever patient agrees for, and then hormone therapy depending on the menopausal status. If the the grade is 2, patient is not keen for any chemotherapy, patient is frail, we will go for the can assist also.
Lalit, you agree with that?
Yeah, totally, sir.
Nitin boss?
Yeah, definitely. I mean, I never go against my medical oncologist.
In fact, Nitin is very keen. He interferes only with the surgical part. After surgery, Nitin said, now it is your domain. So he doesn't come in between.
Great.
So, they have a lot of drugs now. They can treat good. I mean, we can give good outcome with all, discussing with our colleagues. So let's do the same as they want.
So just for my surgeon colleague, one important input about this patient, like there is one trial called ADEPT trial. So they are documenting that in patients who are HR positive, HER2 negative, where the gap between the diagnosis and the surgical intervention for early operable breast cancer, you give hormone therapy for 2 to 4 weeks. And then you reassess them if the patient is showing clinical improvement in the form of shrinkage of the tumor. Or second thing, you do a repeat biopsy, and if the Ki67 goes down from say 25% to 5%, this subset will be responding to very good to the neoadjuvant hormone therapy.
So agreed with that, boss, what will happen to the sentinel node biopsy we do in these cases?
No,
do we have data for it that SLNB will be same as of non-neoadjuvant part?
No, in fact, it is like I'm not sure about the sentinel node, but in early operable breast cancer patients, they felt that 2 to 4 weeks time is given for the logistics. Sometime with the busy surgical like OT list, you are not able to operate upon. So rather than giving NACT in operable, and the advantage they say not achieving the PET-CR, the advantage only conversion from MRM to BCS. But that is one approach. Will probably in next few years we may see that.
Okay.
So over to
Sir,
you, Uttam, for
sorry to
your.
interrupt you. Can you please conclude the talk?
अरे स्वरंग इतना बढ़िया चल रहा है और तुम बंद करने को बोल रहे हो.
Sir,
So
we are already.
we're finishing off in 5 minutes, please. Thank you. So we had this patient. This patient had chemotherapy, and she had she was advised letrozole with ovarian suppression. What about radiotherapy? Manish, you around?
Yeah. Good evening, boss. I am around.
Good evening.
So definitely this patient will require adjuvant RT. There is no doubt about it. BCS है, young patient, and one node is positive. So there is no ambiguity about deciding for whether she requires radiation or not. She definitely requires adjuvant radiation.
So what would be your area of radiation? You know what?
Yeah, so that is the rather interesting question because we all know radiation is required. So we are going to treat the breast of this patient. We are also going to treat the axilla of this patient. This patient fits into exactly the Amorous kind of situation, that clinically N0 with axillary mapping and getting a sentinel node positive into a node positive into sentinel. So I'll address the axilla also, and thereafter will give a boost to the lumpectomy cavity.
So does it not increase the lymphedema rate if you add an axillary radiotherapy?
So this point also I wanted to discuss, because just previous to this talk, Dr. Uttam was mentioning some comment that radiation, again, if you are trying to address axilla with radiation, it is going to be disastrous. So when we see the Amorous or any other trial where Amorous was the right trial, where it compared head-on with the surgery versus radiotherapy, it showed that with surgery, the rates of lymphedema was around 20 to 24%, whereas the patient who underwent radiation for axilla, the rates were somewhere around 8 to 10%. So it's not that detrimental as a surgery can do in terms of lymphedema. So the risk is much less. It's almost 50% of what we used to see with the surgery.
But that depends, how much axillary dissection we are doing. Are we doing lower axillary dissection or SLNB versus complete axillary dissection? Definitely.
So I'm talking about the same scenario. Amorous addressed the same with SLNB done onto the patient with N0 node. So what the data I am telling is exactly fitting into the current patient we are having. Yeah.
Agreed, but SLNB will never get to 20% rise in the lymphedema. It will never be.
I'm just quoting the data of Amorous, sir.
Okay.
I'm just quoting the data from Amorous. I agree with you, because standard axillary dissection lymphedema rates are somewhere around 18 to 20, where you do the complete axillary dissection. I agree with that.
Yes.
But I'm not sure how in Amorous they quoted it around. It was exactly around 24% actually. So I'll address the axilla also, and then a boost thereafter to the lumpectomy cavity. So that is going to be my plan for this radiation for this patient, and the kind of 40 gray 15 start B trial protocol we usually follow. So that has 15 sittings for the breast and 5 sittings to the cavity boost.
So do you ask a surgeon to mark the cavity before closing the BCS, or it's okay?
So wherever we attempt BCS, we definitely should have a protocol in place to make it easier for us to identify the cavity. So to plan a lumpectomy, we usually either fuse the PET scan, we take the scar into account, we also see the markers placed into the cavity. So this makes the lumpectomy boost more accurate, and it should be done ideally this way only.
Thank you.
भाई मेरा रेडिएशन ऑन्कोलॉजिस्ट मनीष है, इसने जो बोल दिया वो पत्थर की लकीर हमारे लिए। I think
Sorry to interrupt, sir, but we need to conclude.
yes. I think it was a wonderful discussion till now. We were supposed to carry on forward, but time is the constraint. Thank you very much, all of you on board, and thank you, Lalit, for getting me on here. Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you. Thank you, everyone.
So, thank you so much, Dr. Uttam sir, for that wonderful moderation. Thank you, all the panelists, for that wonderful discussion and making things rather more clear to us. For the next session, I would like to invite a very dear friend of mine, Dr. Rohit Swami, as the chairperson. He's a senior consultant medical oncologist at Narayana Multispecialty Hospital, Jaipur. Over to you, Dr. Rohit.
Thank you, Dr. Lalit Sharma, for giving me this opportunity. And I'd like to invite Dr. Divesh Goyal for his presentation on Supremo clinical trial. Dr. Divesh Goyal is a senior medical oncologist at Fortis Jaipur and a very dear senior. And he'll be presenting Supremo trial today. So, to you, Dr. Divesh Goyal, boss.
Thank you, Manoj, as well as thank you, Lalit, for giving this opportunity. Just we will conclude within 3 to 4 minutes. And we all know that this Supremo trial, so does post-mastectomy radiotherapy in intermediate risk breast cancer impact overall survival? So 10-year results of this big 2-4 MRC randomized trials on behalf of this Supremo trial investigator. Slides are not moving. Can you share from this side?
Sure, sir, I will share.
Yeah. Yeah, next. Please change the. So we all know that the where we are using this radiation. So Danish and Canadian trials of 9 to 10% of survival benefit at 10 years from addition of RT to this systemic therapy. So as shown in this graph. So we all know that this the standard treatment for T3 as well as the node 4 or more than 4. So role of this RT in this 1 to 3 node, that is research priority. Next. So we all know that P, T1, N1, T2, N1 or T3, N0. So in this main eligibility criteria, we confirmed this histologically confirmed invasive breast cancer with P, T2, N0 grade 3 or lymphovascular invasion. These patients undergone simple mastectomy and axillary staging procedure. And if axillary node clearance, node positive, 1 to 3 positive node, then an axillary node clearance minimum of 8 nodes removed have been performed. So there is axillary node negative status can be determined on the basis of either axillary node clearance or axillary node sampling or sentinel node biopsy. And these patients are fit for adjuvant or neoadjuvant treatment and adjuvant endocrine therapy with written informed consent. Next. Next. Please change. Swarangi.
Surangi, please change this.
Yeah. So in this trial, the endpoint is primary overall survival at 10 years and secondary endpoints are local and regional recurrence, disease-free and metastasis-free survival, cause of death, acute and late morbidities, quality of life, as well as cost effectiveness. Next. So next. So in this, there is the patient was randomized to no chest wall irradiation compared to the chest wall irradiation. Next. So all the parameters were very well matched: age, histological grade, number of nodes involved, tumor size, TN stage, HER2 positive, triple negative. Next. So in this, the Kaplan-Meier curves for this population overall survival as shown, there is no difference between the no chest wall irradiation compared to the chest wall irradiation. Next. So even N0 or N1 status, there is still no difference. Even with this N0, even with this N1. So there is no difference between no chest wall irradiation versus chest wall irradiation. Next. I think in this still same, the local recurrence was same even with this no chest wall irradiation or chest wall irradiation. Next. And the next, even with this nodal status, there is no difference. Next. So even with this regional recurrence was same. The next. Next. So the conclusion of this trial. So in this patient with 1 to 3 positive node or P and 0 with other risk factor adjuvant chest wall irradiation with optimal systemic therapy doesn't improve 10-year overall survival, result in a clinically insignificant reduction in 10-year chest wall recurrence, less than 2%, has no impact on disease-free or metastasis-free survival. Incremental improvements in multidisciplinary care probably explain these results, and adjuvant chest wall irradiation should be omitted in most patient meeting eligibility criteria for this Supremo. So, thank you. So I think we should avoid this as shown in this eligibility criteria. So we can avoid this adjuvant radiation. Thank you.
Thank you, Divesh boss. So next I will invite Dr. Manoj Mahajan boss to have the panel discussion, case-based panel discussion on hormone positive, HER2 negative breast cancer. To you, Dr. Manoj Mahajan.
Thank you, Dr. Rohit. I'm traveling, and thank you for accommodating and rescheduling my talk as I have one more meeting afterwards. And I would like to thank at the outset Dr. Lalit Sharma for conducting this wonderful session and giving me the opportunity for the moderation. So I would like to invite my panelists, Dr. Anushri, Dr. Ankur, and Dr. Abhishek. All A stars are there. Uh, are they? Have they joined?
Yeah, I'm here, Dr. Mahajan.
Yes. Hi. Hi. Good evening.
Good evening.
So I think already we are delayed schedule. We'll try to finish it in couple of minutes or 15 to 20 minutes. Will not exceed our time. So the discussion is between how to proceed when we fail with the hormone positive patients, HER2 low patients with standard hormonal therapy. So can we share the slides? So next.
So slides are visible?
Yes, slides are visible. So here is the example of the case which we commonly encounter, like 50-year-old postmenopausal female in the rice breast lump. Biopsy is IDC, grade 2, ERPR is 70%, HER2, IHC 0 or negative. T2N0M0 disease received 4 cycles of TC, followed by BCS, followed by RT and adjuvant letrozole. Patient's germline HbA1c panel is negative, and patient had lost follow for 5 years. Next slide. So many a times, this is quite common scenario. Once we start with the hormonal therapy, patients, especially those who are in the periphery, we tend to lose them for a regular follow-up, and then they suddenly pop up with the low backache, and which is quite common. And MRI in the same thing happened in this patient as well, and then MRI was suggestive of bone mets. So next slide. So obviously, if MRI is suggesting metastatic lesion or bony lesion, we go for the PET scan, which is showing the pleural base lesion plus pleural parenchymal or bilateral lung lesions, mediastinal lymph nodes with multiple liver lesions, lytic bony lesions. So this is a florid disease involving pleura, lungs, mediastinum, liver, and bones. So how do we proceed from here? Dr. Anushri?
So initially,
Next slide.
the disease has come again and with metastatic. The re-biopsy is suggestive of again hormonal positive and with HER2 1+. So if the patient had progressed on letrozole, so best in the condition with patient basically hormone positive and no visceral crisis as such, and mainly skeletal mats, we should go ahead with CDK inhibitor.
And hormonal, like
And
hormonal
combination
part with
letrozole, so we can combine with fulvestrant.
how many patients, like let's say we have 100 patients. So how many patients you go for the re-biopsy in such situations?
Usually, if the patient at outset having more of the skeletal mets and patient initially had hormone positive, in that cases, I go ahead without rebiopsy because it does matches with the disease biology. But if the aggressive disease is, if it does have a very aggressive disease, like if lung match is flared and liver match are there, so I do press upon the need for rebiopsy in such cases.
So what would be the percentage? Like
I'll
roughly
guess 40 to 50%.
so half of the patient will go for the rebiopsy.
Yes, but if
Dr. Ankur,
the history and biology or long history in relapse and a long skeletal lesions, so it's okay to at least start them on CDK inhibitors combination.
okay, Dr. Ankur, what would be your percentage?
So I will advise a repeat biopsy for almost each and every patient who recurs. Because might need, tissue for some other markers as well. We get prognostic information as well. Now we have HER2 as well. So I prefer to do a repeat biopsy and then start treatment.
Yes, Dr. Abhishek.
Yeah, sir. So I offer to all patients and try to convince for biopsy. If patient is a good DFI, he is easily convinced for the rebiopsy. But if it's early progression, that is difficult. Otherwise, more or less, patient are convinced for the rebiopsy.
Okay, next slide. So I think most of us do rebiopsy, even as Dr. Ankur has pointed out, and newer markers are coming like ESR1 and all other markers are coming up. We should try to go for a rebiopsy for most of our patient, with exception definitely if, like as Dr. Anushri has pointed out, only bone mets. In that situation, it becomes little difficult to get the biopsy, but we should go for the biopsy. How many would opt for the liquid biopsy in such cases if there is a no biopsiable lesion? Dr. Abhishek or Doctor? Will you go
Sir,
for liquid biopsy?
No,
If
sir.
let's say a patient has only bone only mets and no other site where you can see biopsy can be done.
No, sir. For a liquid biopsy in breast
And
metastatic, I still not.
finances are not an issue.
Yeah, sir. But still but also still because liquid biopsy in breast, I think I am still shaking my hands before liquid biopsy because yeah, we can do ESR through liquid NGS, but I'm still not happy with this in breast, sir.
Okay, Dr. Ankur, do you have any difference of opinion?
So yeah, if a patient is willing, I will prefer to do a liquid biopsy because soon might we will be able to have the option of giving a PIK3 inhibitor upfront, and we might get some prognostic information regarding ESR and other mutation as well. But I have to counsel the patient that it's better do a consecutive liquid biopsy rather than just do a baseline biopsy. So when patient further progresses, if we do a repeat liquid biopsy, it might tell us more information regarding the tumor.
Yeah, Dr. Anushri, you have.
I won't go for a liquid biopsy at the outset. I'll give because ultimately more data is for liquid biopsy. I'm planning for PI3K inhibitors. So not at the outset, but yes, if the disease progress, then if there is no tissue, then it's better to go for liquid biopsy in that setting.
Okay, so it's a little difficult, critical situation. There are no recommendation as like Dr. Abhishek. I'll say ki all the opinions are accepted, but it depends on the situation. If patient is willing for all the testing without any financial constraints, I think we can go for the liquid biopsy as well, where we will have a better understanding of the disease biology, which may be mutated or which may have changed its nature, though previously it is slow growing or responding. So looking at the whole genomic picture would definitely help us in deciding the right choices. So next slide. So as like we know, rebiopsy is usually done to look for the change of the markers. There are sometimes few of the patients do change from the hormone positive to hormone negative or HER2 negative to HER2 positive. So the classical incidence we say around 3 to 5% patient do change such situations. So there is a dynamic expression of the HER2. And next slide. So there has been one. How many, like, what are the chances of discordance in HER2 testing in the in your experience, Dr. Abhishek?
Yes, sir. Because there is a HER2 testing. Basically, we are doing on the basis of the ISC, and you can clearly see the definition with the more number percent cells, more than 10%. What is the intensity of that weak, moderate, or strong intensity? So that's quite subjective, you can say. So you can find some changes in the IOC when you do a different pathologist. And I think Destiny 4 has some good central data. They found some around 20 to 10 to 20% discrepancy between the ISC and other the different central review they done in their patient. So yes, around 10 to 20% discontinuation chances in ISC and HER2
Yes.
testing.
Next slide. So yes, no, Dr. Abhishek has rightly pointed out nearly 80% sample, 78%. So 80% will have the concordance, but nearly 22 will have a discordant, and 12% will have a score of ISC 2 plus or ISC 3 plus if we label it from the central process lab. So if we take a whole cohort, there will be discordance of around 2 to 3% of the patients in the whole cohort. Next slide. So as there are multiple factors, we know from sampling handling to biopsy types to cold ischemia type and type of assay. So there are multiple factors which influence HER2 expressions. So I think that is why we have to be careful with respect to HER2 testing and assay reporting. Next slide. Dr. Ankur, can you take this? There are gaps in the definition of the HER2 IHC?
I think now it is more or less standardized by the CAP guidelines that when to be define HER2 IHC. Only thing there have to be proper interpretation, and what I feel is the proper use of a proper antibody, which makes a lot of a difference. As per definition, I don't think there is no any ambiguity now, because we have now clear cut guidelines even for HER2 low. There are clear cut guidelines to define them.
Yes. Next slide. Though the guidelines are quite clear, the one part which is like weak to moderate complete membrane staining or strong incomplete membrane staining, this is slightly subjective, I feel. Though the latter half of the part has been clearly defined, but weak to moderate is again it's a qualitative marker which may be a subjective. So these are the gaps. Probably we'll need a better understanding, and as we are going for the next generation sequencing on the solid blocks as well as liquid biopsy, that will give us a better idea in terms of HER2 expression versus HER2 amplification as well. So there are certain gaps, but still, as Dr. Ankur has pointed, these are standardized and we have a better adaptability in most of the patients. Next slide. Dr. Anushri, is the plan treatment based on initial biopsy or rebiopsy? So
It
if we don't,
depends. If the rebiopsy, we do have a targetable marker. So yes, if there is a targetable marker, be it ER positive or HER2, so that will be the deciding factor for the further treatment.
okay, next slide. So this is a like expert opinion. category of evidence is like 87% have these biopsy of metastatic lesion. So this concludes there is ambiguity. Again, we can directly go for the endocrine therapy or anti-HER2 therapy when receptors are positive on at least one of the biopsy, regardless of the timing. So both the approaches can be followed. Next slide. So next slide. So for this patient, next slide. This patient, as she was hormone positive, HER2 1 plus, started on Abema plus fulvestrant. Next slide. And she progressed after 8 months, and then she was started on capecitabine. Again, progresses with the newer bone lesions within 3 months. Next slide. So, what is your next line of treatment, Dr. Ankur? So patient has. I'll just summarize. Patient has recurred, hormone positive, IHC 1 plus, received Abema plus hormonal therapy, progressed within 8 months, started on capecitabine, again progressed.
So this is sort of the ideal patient, to challenge with TDXT for two reasons. Particularly, firstly, they didn't respond and that much prolonged with the CDK4 or hormone therapy. Secondly, they had a lot of visceral disease. So I think this is the ideal patient now to target with TDXT at this point.
Exactly. Probably, I would say before going for the capecitabine, I would have started with the TDXD, because as you are rightly pointed, patient has very short progression-free survival with Abema plus fulvestrant, just 8 months. So I would have started at that point of time TDXD earlier. Next slide. So this is the Destiny for breast design trial, which has the similar kind of patient profile, which has progressed after 1 to 2 prior lines of therapy. So it was given TDXD versus 2:1 randomization with TPC with various options. Primary endpoint was PFS, secondary endpoint PFS and OS. Next slide. So we'll just flip through the data. Both the subgroups are quite well matched in terms of patients to status, ECOG PS, hormone receptor positivity. Most of them, 90% were hormone receptor positive, 10% were negative. Next slide. Number of lines of therapy are again well matched in both the groups. Next slide. Next slide. So we'll go to the result. PFS in hormone receptor positive patients are almost replica of the all patients in most of the parameters. So if we look at the PFS in the hormone receptor positive, it was 10.1 versus 5.4 months. In all patients, it was 9.9 versus 5.1 months. Next slide. With hazard ratio are also matching. OS, if you look at the OS, it is again nearly 2 years versus 17.8 months in both the arms. And the graphs are almost matching each other. Hazard ratio are also matching each other. As most of the patients, 90% patients are hormone positive, so probably that is bound to happen. Next slide. So next slide. TDXD has a better response rates from this graph. Next slide. So there are few questions which we need to address. Activity of TDXD in HER2 low versus sacituzumab govitecan, irrespective of HER2 status. Which one to indicate first? Dr. Ankur?
So if we look at a cross trial comparison, we can look that PFS is definitely much better with TDXD compared to sacituzumab, and response rates were also, I will say, are higher when we use TDXD. So if it would be my preference, I would prefer to give this one first rather than sacituzumab.
Yes, yes. Dr. Abhishek, you have any difference of opinion? We are not
No, sir.
discussing
No,
about the
sir. No, sir.
financial things.
Definitely, TDXD had a better response rate, better PFS when you look at the cross trial comparison, and easily available still in India and quite good real world data also. So TDXD is option.
Dr. Anushri, you have any difference of opinion or?
I'll support that TDXD will be the preferred choice. Although there is a if biomarker can be applied like TROP2. So not proven, but can be used if as FG is preferred in that case.
Next slide. So I think panel concurs with the TDXD's preference, and as we can see, though the cross trial, again the cross trial comparison can't be done, but still we can see the results where Destiny Breast has a median PFS is better. Next slide. So would you have re-challenged the patients with another CDK4/6 inhibitor, Dr. Anushri?
No, because the quite a short period, the progression is there. It's better to explore other option.
Okay, if HER2 were too negative, like let's say HER2 0, it's not HER2 low. In that scenario,
But most of the trial, another CDK4/6 inhibitor have there are few trials that have shown a few some months benefit, but I'll prefer to target something else, be it everolimus or like Bolero 2 trial. So any other pathway I'll prefer in my setting.
Okay, so we'll just see the data. What is the data? Next slide. So these are the few trials, Maintain and PACE, which have used ribociclib plus and hormonal therapy plus and PACE has used palbociclib plus fulvestrant after failure of CDK4/6 inhibitor. But both these trials have most of the patients were failure after palbociclib and a PFS of around 5.5 months around or 4.46 months. So it can be an option, but we can explore the other options as well. Next slide. So what if the patient was germline BRCA positive? So how do we optimally go for the sequencing? Dr. Abhishek? Dr. Abhishek? Hello? Dr. Ankur?
So for a metastatic patient, I would prefer to give it upfront only. Olaparib, patient is BRCA mutated, because the best results are seen the earlier the line the drug is given.
Yes. So most even in the ovarian trial, if we look at the data, it includes platinum sensitive disease. So disease responding will have a better PFS in terms of using the olaparib or PARP inhibitors. But in patients who is already resistant, multi-drug resistance, or in this situations where a patient has failed 2 lines of therapy in very short PFS, so in such situation, olaparib would be questionable option. Next slide.
Sir, sorry to interrupt. Can you conclude in 2 minutes?
Yes. Last few slides. Next slide. So there are current knowledge gaps. As of now, we don't know how to HER2 IHC level will matter to end the TDXD. Because there are data and we are not very sure about the HER2 low where it will change. And the other gap, which will be like maintenance of endocrine therapy for patients who is responding to TDXD and stop due to the toxicity, that we are not sure. So these are the current knowledge gap and we'll need to address. I would like to thank Dr. Ankur for Dr. Ankur, Dr. Abhishek, Dr. Anushri for active participation. Thank you.
Thank you, Dr. Manoj Mahajan boss, and all our esteemed panelists for such a deep, insightful panel discussion. I'll next invite Dr. B.S. Ankit for his presentation on Patina trial. Dr. B.S. Ankit is consultant medical oncologist at SCG Jaipur. To you, Dr. Ankit.
Thank you, sir. Thank you, Lalit's boss, for giving me this opportunity. Can I share my slides from my side?
Yeah, please go ahead, Uncle.
Are the slides visible so I can start just?
In the process, just maybe another couple of.
Is it visible?
Yeah, it is visible, Ankit. Kindly go ahead.
Okay, yeah. I'll just take 2 to 3 minutes because the paucity of the time. So Patina trial is a randomized trial, phase 3 trial to evaluate the efficacy and the safety of triple drug therapy in the triple L positive or hormone plus HER2 positive triple therapy, which means a CDK4/6 inhibitor with the anti-HER2 with the endocrine therapy versus only anti-HER2 and endocrine therapy after the 6 cycles of induction chemotherapy, according to the Cleopatra trial in the metastatic, both the hormone and HER2 positive breast cancer patients. So approximately one fourth of the patients are HER2 positive, and half of the HER2 positive patients are hormone positive as well. And HER2 is the driver mutation, and which makes other kinds of the targeted chemotherapy a resistant one, with the exceptions of the use of hormonal therapy. And now with the time there is ample amount of evidence between a crosstalk between the ER receptor and the HER2 receptor. As we can see, CDK4/6 down regulates cyclin D and ultimately increases the cell proliferation. And same happens with the HER2 with the down regulation of PIK3, AKT, mTOR, and ultimately the cyclin D. So if we inhibit both the receptors, CDK4/6 with the TKI, or HER2 either with the MABs or the TKI in the intracellular setting as well. So we'll able to take control of the disease as well as the resistance mechanism as well. So these were the trials, phase 1B and 2, which was tried these kind of comparisons. But the most important one is Patina trial, and the histologically confirmed ER, PR HER2 positive metastatic breast cancer patient who have never exposed to prior treatment for the metastatic setting. After 6 to 8 cycles of induction chemotherapy with the trastuzumab with the taxanes or trastuzumab pertuzumab with the taxanes, after 6 cycles, the patient was randomized between the CDK4/6 palbociclib with the anti-HER2 with the endocrine versus the control arm was the trastuzumab with or without pertuzumab with the endocrine therapy. And the primary endpoint was PFS, and secondary endpoint was overall response rate and clinical benefit ratio. The stratification point till although the results is not out, the whether the use of pertuzumab will affect or not, whether any prior anti-HER2 therapy was used in the neoadjuvant setting was there or not, and the response to the induction therapy and type of endocrine therapy, either AI or fulvestrant was used. So the median PFS with the use of the triple drug therapy was 44.3 months of the median PFS versus in the doublet it was 29.1. At the end of 60 months, the PFS was 43% versus 33%. So it has a clinically meaningful benefit with the almost the difference of 15 months between the arms. And if you talk about the secondary endpoint, in the triplet, overall response rate was 29% versus 22%. And clinical benefit ratio was 89% versus 81.3%. And if you talk about the grade 3 side effects, measure was the neutropenia, which was statistically significant difference was there, which was 63 versus 2%. Fatigue and stomatitis and diarrhea, although it was 5 versus 0, 4 versus 0, 11 versus 1, but it was not statistically really significant. And the incidences of grade 4 adverse event as well was 12 versus 8.9, again not statistically significant, and there was no treatment related death in both of the arms. So at this time the OS is immature, but median OS has not reached yet, versus in the control arm it is 77%, 77 months, and 5-year OS rates are 74% versus 69%. So concluding my slides, it reinforces that the anti-HER2 therapy in combination with the endocrine therapy, with the addition of CDK4/6 inhibition, overcome the resistance of the crosstalk between both of the receptor. And addition of the palbociclib have significantly showed the improvement of progression-free survival with the manageable toxicity profile and without any new safety signal indicators. With that, thank you so much.
Thank you, Dr. Ankit, for your insightful talk about Patana trial. I'll now like to invite Dr. Anushri Chaturvedi, Consultant Medical Oncologist, Bhagwan Mahavir Hospital, for her topic on 10-year outcomes of Olympia study. To you, Dr. Anushri.
Thank you, boss, for the invitation. Can I have my slides, please?
Ma'am, slides are visible?
Yes, it is visible. So for the interest of time, we'll try to brush it fast only. So my presentation is on pre-specified analysis of IDFS, DDFS, and OS 10 years from the first inpatient in the Olympia trial of adjuvant olaparib in the germline BRCA1 or 2 mutation-associated breast cancer. Next. So we all know that inhibition and trapping, that is the synthetic lethality, is the basis for use of PARP inhibitors in the germline variants, pathogenic variants of BRCA1 or 2. So initially, the olaparib had established its role in the metastatic setting. This study is in the early breast cancer in the adjuvant setting. This analysis and an updated analysis that on the third pre-specified analysis at 10 years from the first inpatient. Next slide. So this is the basic. Here, initially, the central screening for the genetic testing was done. The patient included were the stage 2 and stage 3 breast cancer, both the TNBC variety or the hormone positive variety. The TNBC patient included that underwent a neoadjuvant therapy in combination with the AC therapy or the paclitaxel were also included. And in the adjuvant setting, any hormone positive that were the higher risk, that is more than 4 positive lymph nodes, were included in the trial. And they were, again, stratification was done on the basis of hormone positivity, basis of neoadjuvant versus adjuvant treatment, and with the prior platinum treatment or not. The treatment was done olaparib versus placebo, both for 1 year. Then the primary analysis, the primary endpoint was the interval disease-free analysis, and the secondary endpoint was the DDFS, that is the distance-free survival, and the overall survival. Next slide. So basically, the median age group was 40 years, and both BRCA1 mutation were more around 70-30% ratio between BRCA1 and 2. Majority, that is the 60% were the premenopausal patient, and 80% of the patient underwent mastectomy. Next slide. More majority were the triple negative, and the cohort of the hormone positive were slightly on the lower side, that is the 20%. And mostly patient did receive some kind of chemotherapy, be in the adjuvant or the neoadjuvant second, and taxane and anthracycline were the majority, that is 94%, and around 30% did receive platinum-based therapy. And most of the patient did receive the endocrine therapy also during the adjuvant setting. Next slide. So this was the invasive, in the first analysis, we did see that there was a benefit of invasive disease and a distance disease-free survival. In the second analysis, that is in July 21, there was a trend toward the overall survival analysis, and that was maintained in the 10-year and the 15-year interval also. Next slide. So number of events that did happen were lesser in the olaparib arm versus the placebo arm, and most distance recurrences were more in the placebo arm, and the lesser of the local recurrence was in the olaparib arm. Next slide. So the slide shows that yes, the IDFAS benefit of 4-year was at 8.5, and it was maintained at 6 years also, with a hazard ratio of 0.65. Second slide. This depicts that all the subgroup analysis, all the patient either were hormone positive also or BRCA mutation, be it 1 or 2, and even also if they have received platinum or therapy or chemotherapy, the hazard ratio was favorable in the subgroup analysis. Next slide. Again, the subgroup analysis has discussed the hormone receptor status, that though it consisted of the lower cohort, that is the 20% of the patient, but it also did show us a hazard ratio of 0.6 versus 0.68 in comparison to the triple negative. But the benefit was low on a lower side, but subgroup analysis does favor both the subgroup, be it hormonal positive or triple negative cases. Next slide. Again, the intention to treat population, the distance-free survival also did had at 6 year also the benefit was maintained with a favorable hazard ratio of 0.65. Next slide. Again, there's this slide that all the subgroup analysis did favor olaparib only. Next slide. So basically the number of death, that is important. It was more in the placebo side. And the cause of death, majority were the breast cancer. And it need to be noted that the cause of death, be it the AML cases or ovarian cases, both of them does not have any increase in the PARP inhibitor arm. Next slide. Again, that is important initially after the second analysis, because OS benefit is also being seen in the total population. And as we know in hormonal positive, the OS benefit will take time, and it has also shown favorable in both these subgroups. Next slide. Next slide, please. Again, in the OS also it benefits. Now the adverse event, because we know that if we are using a PARP inhibitor, so if there is no added risk of MDS or AML in such cases, and this need to be noted, and the adverse events were comparable to the placebo arm only. Next slide. So this is because there is as such no the data is being under investigation, but still, as per the percentage we can see in a germline BRCA patient, the incidence of breast cancer and ovarian cancer and pancreatic cancer is on the lesser side in comparison to the olaparib arm. In the olaparib arm, it is lesser in comparison to the placebo. And it does depict that though it investigation, but germline mutation cancer also having an effect by the PARP inhibitor. Next slide. So to sum it up, the data analysis will be complex because quite a number of patients did have a bilateral BSO prior to randomization and quite a few after randomization. So, but it can be seen that both the incidence of the breast cancer invasive and the fallopian or the ovarian cancer were on the lesser on the olaparib arm as compared to the placebo arm. Next slide. again, this is important, and because the number of pregnancy patient that were on olaparib compared to placebo were equivalent number, and the outcome of the pregnancy with the full term mature delivery were equivalent in both arms. Next. So to sum up, in early breast cancer, at a median follow-up of 6 years, with 1 year of olaparib in patients who have received a neoadjuvant therapy and hormone positive high risk patient, the study of olaparib for 1 year did show benefit, be it in invasive disease, distance disease survival, and overall survival, and across all the key groups. And it is important to note that there were fewer new primary malignancy that were seen in the olaparib arm, and there is no such worry as the risk of MDS or AML in using a PARP inhibitor. So these data do continue and support the adjuvant olaparib arm as standard of care in a germline BRCA mutated patient at high risk of recurrence in hormone positive and in the TNBC variety. Thank you.
Thank you so much, Dr. Anushri, for that very crisp and lucid talk. Now we would move ahead to the next session, which is on genitourinary and GI cancers. To chair this session, I would like to invite a very dear friend of mine, Dr. Tarachand Gupta. He's a senior consultant medical oncologist at Bhagwan Mahavir Cancer Hospital and Research Center. And I would also like to invite the very dynamic Dr. Aditi Mittal. She's a senior consultant medical oncologist at SMS Hospital. Thank you for joining us. Over to you, the chairpersons.
Thank you, Lalit. Thank you very much. And I congratulate you on the Madam CME of you, Onco Illuminate, and I wish grand success of this meeting. So, moving towards the topic of metastatic urothelial cancer, I invite a moderator for the panel discussion, Dr. Lalit Mohan Sharma, sir, for the management of metastatic urothelial cancer. He is a senior consultant, hematologist, and medical oncologist, Mahatma Gandhi Hospital, Jaipur. And I will invite panelist, Dr. Preeti Agarwal, consultant medical oncologist, Narayana Hospital, Jaipur, Dr. Ankur Punia, Dr. Ankit Agrawal, Udaipur, Dr. Abhishek Sharma from Jodhpur, and Dr. Pulkit Nag, Apex Hospital, Jaipur. Lalit sir, over to you.
So thank you so much. I hope the slides are visible. I am audible as usual.
Yes, sir. Slides are visible. You can continue, sir.
Pulkit, should I continue? Pulkit, are you there?
Yes, sir. Please. Good evening. Yes, sir.
Yeah, so thank you so much. And I think we will be touching on the practical aspects. So let us start with the landscape and the journey. We all know about these data, and we all understand that for many, many years, more than 25 years, we did not have much to offer to our patients in bladder cancer. In 2017, the immunotherapy was practiced, and it was documented that in patients who are cisplatin ineligible, so this immunotherapy works in different capacities. And now we know about the immunotherapy part, and we'll be discussing about the immunotherapy aspect. So we all are aware about the Javelin bladder trial, and we understand that this is the induction therapy followed by treatment-free break of 4 to 10 weeks. And then patients who were responding, they were divided into two randomization. 1:1 randomization. So one was getting avelumab, other was breast supportive care, and the primary endpoint was OS. So with this background, we move forward and we see the median OS was higher. It was 29.7 months in the avelumab plus best supportive care arm. It was 20.5 in the best supportive care alone. Also, there was a delta of 9.2 months, and that made this drug efficacious, especially in the metastatic or cisplatin failure patients. So, coming to the panel, Dr. Preeti, let me start with you first. One is which patient you find cisplatin ineligible in practice?
Good evening, sir.
Cisplatin ineligible, most commonly in bladder cancer, we find patients whose GFR is less than 60 ml per hour, or performance status is poor, C more than 2, PS more than 2, or those who have poor ejection fraction with heart failure of NYHA class 3 or more, or significant peripheral neuropathy, or having hearing disability. These are cisplatin ineligible patients.
Agree. And second thing, Dr. Ankit, to you, that do you find any difference in the cisplatin versus carboplatin in these patients in practice?
Yes, sir. I think the related to toxicity profile, we are very comfortable in using carboplatin as compared to cisplatin, especially nausea, vomiting, nephrotoxicity. Yes, we do see some nephrotoxicity with cisplatin, not very commonly, but we are very comfortable in using carboplatin.
Pulkit, do you find any difference in the response between cisplatin and carboplatin uses?
Yes, sir. Sir, there is not such a major response, but whatever trials have done, they are more comfortable with that. So, as per the theoretical purpose, but on clinical practice basis, there is not such a major difference between the users.
Right. So, Ankur, like any inputs on the trial design or anything you suggest, or you are happy with this?
So I think a good trial design. They've selected a good, population of patient who were responding. Particularly took out the patient who didn't respond to therapy. Those are around 10-15% of the patient. So a little bit of hyper selection. A few patients who might have benefited from immunotherapy were, kept out of this trial.
So I think that is very important that they have selected the subset of patients who are already showing good response. And we know that once the patient shows good response with subsequent also, they are likely to show good response. So the resistant variety, which of course is 10 to 20%, but they have excluded these patients. And these are the results. They have shown that patients who received cisplatin, the median OS was 2 months higher, 3-4 months higher as compared to patients who received carboplatin. But again, like it's our practical decision based on the various parameters. The response again, as discussed by Dr. Ankur, so they have selected very wisely the patients who are showing either CR, PR, or stable disease, and then they have subdivided these patients. And this all we understand patients who are achieving good CR, we can see the response rate in the median OS is higher as compared to patients who are achieving PR versus patients who are like on stable disease. So we all will be moving forward. Yeah, important point. Dr. Aditi, you also want to participate with us?
Yes, sir.
Great. Thank you so much. So I'm adding your name also in between. Thank you so much for joining us. So Aditi, over to this question that in patients who are showing good response, for how long you will like to continue with the maintenance avelumab?
So avelumab is quite easily tolerated drug. And of course, as per the trial design, they say that you have to continue till the progression.
So
But
in practice, if finance is not a barrier,
yes.
patient is tolerating, responding, for how long will you like to continue?
So, yeah, till progression.
Okay, good. Ankur, you also agree to Aditi or you have some different thoughts?
Yes, sir. If patient is able to take it, then I'll continue till progression.
So I think we all agree that ideally in responding patients, those who do not have significant toxicity in any form, maybe financial, maybe other toxicity, we continue with that. So these are the graphs for you that patients who are showing the median PFS of 26.7 months in patients who are exposed to Bavencio maintenance for more than 12 months. So they recommend that we should like try to give it for 12 months in practice if possible, or minimum is 6 months. Again, there is like we all understand our limitations, but they say the patient's exposure should be average of 1 year before we reach to any data. And these are the other two important trials. So Pulkit, anything related to like use
Yes, sir.
of any of these nivolumab plus gemcitabine cisplatin or EV?
So EV, I have evidence of EV, but yes, I have one patient whom I started on de novo JLS nivolumab upfront. So my one patient is currently going on, sir. It has completed 3 cycles, till good clinical response, but I have not gone for the radiological response as per yet. But no any kind of experience with EV plus PEM, sir.
Dr. Preeti, you are working in a very, very rich specialty in railways. So do you find any barrier of use of these? And if given a choice, what will you like to use?
So, I've used Gemsys Nevo. I've used Gemsys followed by Avelumab maintenance. EV as of now is still not available in India. One of the patient, Rohit Bose, is undergoing taking EV in our hospital, which is being imported. So EV has actually very good response. EV is like all other antibody drug conjugates. EV has actually very good responses. And Gemsys Nevo, I had 2 patients referred from Tata Memorial Hospital. They had planned Gemsys Nevo, and I've continued Gemsys Nevo. Avelumab maintenance I've given. I think clinical practice, I think they both work similarly. There is no head-on-hand data. Gemsys Nevo versus Avelumab maintenance. There is no head-on-head data, but clinically both work equally. In my clinical practice, it both work equally well. Although, if we see numerically wise, Gemsys Nevo data is seems to be less impressive compared to maintenance Avelumab data.
Right. So, Dr. Ankit, any inputs on what she says? Like the Javelin people, they were smarter. In fact, you agree that they have designed the trial that they took only patients who were showing good response.
Yes, sir,
And
definitely. A very smart move by taking only responding patients. And I think one more probable reason might be Avelumab is given every 14 days, and when we give Gemsys or Gem Carbo, it's practically not possible to call the patient every week to give Nevo, to give Avelumab and Gemsys. Probably that might be one more reason why Avelumab was given only as maintenance. But I think I'll agree with Dr. Preeti. Checkmate 901, as expected, probably because of the immunotherapy, has not shown a very good improvement in the progression-free survival. The progression-free survival improvement is just probably 0.3 or 0.4 months, which is expected because we don't expect nivolumab or any immunotherapy to go for a good progression-free survival. It is a long term that we look at when we give nivolumab. So, but yes, numerically, Nevo has not done a great benefit as compared to Avelumab, probably because of the population selection and a smarter move by
great.
the.
Dr. Ankur, question to you, like if a patient comes to you, will you check for PDL1 or without checking we are giving the IO to these patients, whichever choice?
So without PD-L1, so it has been shown that patient in bladder cancer doesn't respond based on PD-L1, so doesn't make a lot of a difference to do a PD-L1 testing. I will advise irrespective whether PD-L1 is low or high.
So you will agree to this point that PDL1 testing is not required to treat metastatic urothelial cancer, or anybody has difference of opinion?
I think sir, there's no data to say that, but yes, the trial has suggested that those patients who had a PDL1 positive status or a high PDL1 had a better response. But yes, I think guiding our therapy based on PDL1 is not currently indicated.
Dr. Lalit Sharma, you have some point?
Yes, sir. Regarding the PDL1, I would agree with the panel that it's not mandatory for adding, but probably it can, to some extent, probably let us know whether it is going to work for us or not. But then again, we all have patients who were PDL1 non-expressors, but they showed wonderful results with the IO, be it any IO. And as far as the efficacy of the various molecules is concerned, though we do not have any head-on trials, and this is just I'm mentioning one patient of mine who was on avelumab maintenance for say around almost 6 months, and then he unfortunately had to go for PCNL, bilateral PCNL. Unfortunately, at the PCNL side, bilaterally he developed the disease recurrence. Now, because there was a kind of significant gap, so we somehow continued with evolumab and added gem carbo for just 3 cycles. He responded wonderfully well on the local site, and then we did put him back on evolumab maintenance, and he's doing wonderfully good for the last 3 months on that. I don't know. This is just one case we had at a center.
Great, thank you. Aditi, can you say something about this? Differential censoring remains one important aspect in many trials. So either you or anybody can take this call, that what is this differential censoring and what do we mean?
I think, sir, it means ki how you are taking the patient, whether you're taking the whole population or you're selecting the good performance status or the patients who are responding. And depending on that, you are having patients as your overall survival matters then.
Ankur, yes, you said partly right. Ankur, any inputs on this? Because this is important in various trials. And I also read, in fact, while preparing for this panel about this.
So there thing happens that patients are taken out, the reason is not known, and that might, favor one arm or the other. So it's sometimes difficult to say unless until we have a follow-up data what happened, that PFS2 data. Without that and what further therapies patient have taken, it's difficult to tell whether that censoring has how much affected the eventual outcome. Without that data, it's almost impossible to say what eventually happened.
So I think that is very, very important that like if we see in this checkmate 901, they are saying that no, this particular try I am Vigor 130, there was more than 30% axis censoring in the chemotherapy only group in keynote 361 and other trials also. So if you are censoring the data of say close to 25-30% of the patient, we may not be getting the right answer. But I don't know how the ethics committee and how does the statisticians they manage all these things, but this is very important to learn that if you are not able to take into account all the patients in analysis, how justified are we to take these results? Any inputs by any of you on this data censoring part, or can we move ahead?
So, just a point. So that's why, sir, it's always said that more data is required, as more trials proving the same drug efficacy, like repeatedly, will be more. We'll develop more trust in those drugs. But if there's only one data, then of course there should be more data, and if there are more data, then differential censoring can be taken in account.
Very true, but in fact, for building our trust, the sponsors and the companies will not do repeated trials for the same molecules and same indication. They will try to like generate one data without PDL1. You give everyone, you give the IU and the response. So they will try to convince us that our drug is probably working in all subsets, and that's what the whole US business goes. So this we have discussed CM901, then eligibility for the 3 first-line regimens. So now we have 3 things available. Dr. Abhishek also has joined. Dr. Lalit, Abhishek has joined.
Actually, Abhishek sir has one patient, so he's not able to join the session.
Okay, no issue, sir. So we continue. So Dr. Preeti, any further input, like you have now 3 drugs available to us. So any preference that how do you select which is to be taken?
First line setting, sir.
Yes, first line.
Gemcis versus Gemcarbo versus MVEC or immunotherapy.
No, I'm talking about the IU related first line.
So I don't have any preference, personal choice. So if EV would be available in India, then and it would be affordable to the patient, then EV plus Pembro will remain the first line because it has shown superior survival compared to chemotherapy arm. But till now, Gemcis Nivo versus Gemcis Evolumab. Personally, I like to give Gemcis Evolumab because it chooses the patient, or it chooses the patient who are going to respond to immunotherapy. Otherwise, there is no head-on-head trial. So both Gemcis Nivo is okay and Gemcis followed by Evolumab maintenance is okay.
Very good. Thank you. Dr. Ankit, how many patients you feel they are able to go for the second line treatment in metastatic urothelial cancer after failure of one line?
Less than 20%. Less than 20%.
So, Dr. Ankur, you also agree that like around 20-30% only they are able to go for second line treatment. So the
Yes,
first line treatment, Dr. Preeti said, should be very, very strong, very robust. But again, the affordability and all logistic issues remains important. But the treatment should be robust enough, and EV is probably one of the most promising treatment. And this is the response achieved by the first line treatment like platinum based chemotherapy. And we can see that majority of the patients do respond, and almost 80% of these patients in different studies, they are showing response to the first line platinum based chemotherapy in various combinations. Checkmate, I think we have discussed, and this is important. So, Pulkit, you also agree that if finances is not a barrier, you will use this combination of EV plus Pembro?
Yes, sir. Given the toxicity profile of enfortumab vedotin, we need to check some pre-visits regarding the patient having any skin toxicity or any previous diabetes history. So if that is under control, then on the efficacy basis, it is the best combination who has given the maximum OS and PFS benefits.
Dr. Aditi, you also agree to this, or you feel that you will reserve this drug for second line treatment?
So I think I will reserve this drug for the second line treatment because GEMSIS has shown response for yes, if the patient is fit for 80% of the patient. So maybe reserve it for further.
So I think this is one school of thought that you keep it reserved if the patient, like in the second line, you may use this, in first line, you can use the chemo plus avelumab. Dr. Ankur, you also agree, or you are
No,
not?
sir. So I would like to give in the upfront setting, as we already discussed, quarter of a patient might be able to take a second line treatment. And why to keep such a efficacious drug for the second line for majority? So if possible, this will become eventually the first line standard treatment for me.
Yeah, might be. In fact, in few years we may see these, and so this is the patient eligibility in various, that 80% of the patients, they are eligible for various trials. Do these patients reflect similarity? So, Dr. Ankit, in your practice also, like the metastatic urothelial cancers, what percentage are able to go for immunotherapy?
So clinical practice, less than 20% are affordable for. If I take into consideration the logistic issues, more than 80% will be going for simple chemotherapy, no immuno for them. But I would be for my first choice would be EV plus Pembro in case if affordability is not an issue. I would love to use that drug once it's available in India and if logistics are not issue.
Yeah, so I think that ADCs they are making huge impact. So this is about various trials, that different trials, they show that 12 months OS remains between around 70 months, and the 70 and the PFS also remains around 5 months. This was a poster presentation by Dr. Vineet Talwar and group, where around 50 patients they have enrolled, and they also found that the 12 months OS rate was close to 80%. So these all makes huge difference, and these are various other drugs available. And this is like for the EV plus pembrolizumab real world studies, they again suggest the 12 months PFS rate varying between different from 30 to 55 months. So again to Dr. Ankur, that do you feel based on these evidences, the EV or the avelumab, you feel that in clinical practice, if finance is not a barrier, we should use in all patients?
Yes, sir. If possible, we have the option. So my preference will be to use this drug for patients who can take it. I prefer to give Gemcis followed by avelumab.
So I think that is also very, so everyone agree that to affording patient, we should give the full benefit of IO. And in fact, many patients, those who come into the the last tail part, in fact, around 20-30% of these patients, they continue showing good response. So we should give.
Lalit sir, one question from my side.
Yes, sir.
We are talking about the best drug and pembrolizumab and enfortumab vedotin. So what about the worry? My worry is about the peripheral neuropathy.
So, in fact, we all are discussing that if the patient is tolerating from all angles, then we continue. Of course, we all keep monitoring each patient baseline as well as periodically.
Because we have seen the vedotin compound with the brentuximab vedotin that has shown a very the worst peripheral neuropathy.
That is very true, in fact. So we need to keep that also into account. Any comment by anybody about the peripheral neuropathy part? Because that vedotin is definitely like brentuximab. We are seeing peripheral neuropathy remains major side effect in our patients. Of course, that is likely to be, but in patients who are not tolerating well, this remains the best option.
Even this vedotin compound causes ataxia till the peripheral neuropathy is so worse that it causes ataxia till the last cycle comes. I have seen in one or two patients with the brentuximab, then I burned my hand. I felt like I have burned my hand with the vedotin.
In fact, if you, yeah, that is very true. And I don't know how many of us have experienced, I have not experienced the EV plus P or EV also. I think you might have experienced, you are dealing with many dwellers and rich people, so you might.
No, sir. No, sir. This was with the brentuximab vedotin only. And I tried in the ALCL, then after the cycle 5, patient was responding very well. That response was very beautiful. But patient was in
I think,
ataxia.
Dr. Tarathan, in the interest of time, we will just wind up in next 1 or 2 minutes. So, in fact, we are doing mutations. So, one important point is alteration in the TP53 and KMT2D mutations. It has been linked that patients with these mutations, they may have inferior response to this EV plus P combination. But again, like these all are theoretical. Once things come to us, then we will be able to know it. I think sequencing we have discussed, and on this keynote we will not discuss. So I'll be coming to the last part, that how do we sequence. So Ankur and Dr. Preeti both have agreed, and Aditi is behaving bit conservative कि पहले थोड़ा बचा के कम देते हैं, बाद की अच्छी चीज बाद में दे देंगे. So that approach is one. So Dr. Aditi, over to you. Based on the discussion, based on the data, still you feel that we should give EV as second line treatment?
So, sir, so yes, as we discussed, yes, of course, still not hands-on experience with EV. So maybe if I use, then maybe my outlook would change. But for now, yes, GemCis, if the patient is cisplatin eligible, I would go with GemCis followed by avelumab maintenance. So, and if there is any, or Nivo GemCis may also be used.
So in fact, that is very practical. Dr. Ankur, you also feel the same, or you feel that we can keep this EV as second line in fact?
So still, I will prefer to use it upfront.
Upfront?
Yes, sir.
If finance is not a barrier, but in fact, if you see the ground reality is our patients are not able to go for EV. So we are using this, but again, like we keep the reserve, and we hope that in coming few years, probably the EV may also come with some patient assistance program or some other data or something else, so that the things become more affordable. Ultimately, these all are our own patients, so we need to be very careful when we select any drug, especially in metastatic disease. But we can see that even in metastatic disease, now we are able to see the survival going beyond 3 years, in fact, which was previously for few months only. So I think with this, we will wind up. And any last comments from each of you? I'll start with the females first. Dr. Aditi, from your side, any comments?
So, sir, I think before few years, metastatic CAUB had a very worse prognosis, PFS and OS. But now IO has really put on a new, there will be new landscape, like the CA lung has gone. I think it's a new era.
Dr. Preeti, from your side?
Completely agrees. Completely agree with what Dr. Aditi has said. IO has changed the era. Now we are seeing patients surviving beyond 3 years or so on immunotherapy in urinary bladder, which was never seen before. So, and this is a beginning of new era with the addition of ADCs coming up. So, probably we are going to see more and more improved survival.
Dr. Ankit, from your side, anything to improve the outcome of patients of CA bladder?
So one point I would like to add is still what is an unmet need is getting the biomarkers done upfront for deciding the treatment plan, because still I think it's we don't have a biomarker guided treatment as of now. We are solely relying on the trials, basically the javelin bladder and the EV trial. So I think getting the biomarker done upfront and deciding the treatment based on biomarker related treatment is what will be the next that will be a big thing in bladder cancer, I think.
Agreed. Dr. Pulkit, from your side, anything you suggest to improve the outcome of the UV cancer patients?
Sir, I'll go with still the conservative approach, because the chemotherapy sensitivity, we have a long experience with it. So the better to improve the outcome for any de novo metastatic advanced patient is to still go with the 4 cycles of Gemcis or Cabo, see the response. If it's good, then go with the immunotherapy maintenance. I'll still try to stick to that and will reserve EV plus Pembro for the more future results for that.
Very, very right. डॉक्टर अंकुर, फ्रॉम योर साइड, इनफैक्ट मुझे तो गाड़ी अटकती है मेनली कि जो सर्जन हमारे पास कटिंग करके भेज देते हैं. आई फील दैट वी शुड ट्रेन आवर सर्जन्स आल्सो, so that before taking the bladder cancers, they believe in us to impart the benefit of neoadjuvant therapy, so that we can like get some benefit, because we are fighting many times with the surgeons that please do not do surgery first. And unfortunately, patients are so much in confidence and faith with them that they don't listen. Dr. Ankur, last line from your side. Anything you suggest for metastatic urothelial cancer other than what we have discussed?
So I think, sir, the ADCs are the future for bladder cancer, because bladder cancer is not a highly chemosensitive disease. Response rates are not that much great. So what I feel, ADCs will change the landscape of bladder cancer.
I think that sounds very, very important, that the chemotherapy will be probably out, in fact, in our lifetime. And the MABs and the IOs will also be probably in your lifetime. You may see them going, and the ADCs will be probably the future. So with this, we thank all the panelists and all the participants, Dr. Lalit Sharma, for giving us an opportunity to discuss the urothelial cancers, which is again uncommonly discussed. So over to you, Dr. Lalit, for next proceeding.
Thank
Thank
you,
you so
Lalit sir.
much. Yeah, please
Yeah, Dr.
go ahead,
Tara.
Dr. Tara, please go ahead. I just wanted to
Yeah.
thank Dr. Lalit Mohan sir for that wonderful moderation. Dr. Tara, over to you, please.
Thank you. And for the next is we are moving towards the GI session, and this is also a market sponsored session. I will invite Dr. Abhishek Charan, Senior Consultant Medical Oncologist, SCG Cancer Hospital, Jaipur, for a talk on making a right start, the first line treatment option, and a RAS wild type colorectal cancers. So, Dr. Abhishek Charan, please.
Yes, sir. Good evening to everyone, and thank you, Lalit sir, for this opportunity. Can we have the slide, please?
Just a moment, I'm just uploading the slides. So slides are visible?
Yeah. Yeah. Next one, please. So the topic allotted to me today evening is treatment decision in metastatic CRC. So when we start the treatment for the metastatic CRC, what are the most common points that we keep in mind while picking the chemotherapy or the regimen we are choosing? So one is the age, second is the comorbidity, and I think the third is the primary tumor location, and fourth is the biomarker. So out of all these four, I think tumor location along with the biomarker which are the driving force for deciding the chemotherapy or the regimen which we are going to choose. Next one, please. So this slide shows the evolution in the guideline for the diagnosis and treatment of CRC. We have come the long way for this CRC treatment. Now we have the first line chemo along with the targeted either EGFR targeted or we have VEG targeted therapy which can be chosen. Next, please. So what are the recommendations for optimizing the treatment of left-sided or RAS wild metastatic CRC? Next. Next. Yeah. So there are three landmark trial in the different phases of phase 3 trial in which first line anti-EGFR which involves both either cetuximab or panitumumab along with the doublet chemotherapy demonstrated a median OS survival, median OS and benefit, and it was compared with the VEG targeted therapy along with the doublet chemo. So as we can see in the FIRE 3 trial, which was the one of the landmark trial where the cetuximab was given with FOLFIRI and it was compared with BEV plus FOLFIRI, where the median OS was comparatively better in case of cetuximab along with the chemotherapy and almost 10-month benefit was seen. Overall response rate was also better and it was more than 9%. The same was observed in CalGB SOC trial also where the cetuximab was combined with FOLFOX or FOLFIRI. Here also it was compared with the standard arm of BEV plus FOLFIRI or FOLFOX and the median OS was more than 7 months. I mean the difference between the both arms. So all these trial and the last one is the paradigm which included panitumumab, which is the latest anti-EGFR therapy, which was combined with FOLFOX and BEV also. And it also showed a benefit of 3.45 months. So all these trials have demonstrated that in left side, if there is a RAS wild, so better to go for cetuximab or panitumumab along with the doublet chemo over bevacizumab. Next slide, please. So these are the forest plot which shows the benefit. And in this paradigm trial, the OS curve has crossed I mean, as you can see in the right side, the paradigm left side, RAS wild tumor, the curve has crossed over 28 months. So benefit is more in case of panitumumab along with the chemotherapy. In initial part, the difference was almost same. I mean, there was no difference. But over a period of time, once the graph has crossed 28 months, the benefit was marginally more in case of panitumumab along with chemo as compared to BEV plus chemotherapy. In the left side, as I already mentioned in the last slide, FIRE 3 and CalGB, these are the landmark trial which have established anti-EGFR along with the chemotherapy as first line in RAS wild and at least preferably in left side. It can be used in right side also, but preferably in left side. It has become a standard of choice and first line indication on the basis of these three landmark trials. Next, please. So coming to the ESMO guideline for the consensus guideline, where the patient with the unresectable CRC, as we all know, we can either go for irinotecan or oxaliplatin based chemotherapy, and we can go for BEV or anti-EGFR. NCCN and other guidelines, they do not differentiate much. They give preference to both. But if you come for the left side and if it is RAS wild, then cetuximab is preferable over bevacizumab. And once the patient has progressed on anti-EGFR, there is no point of switching from cetuxi to panitumumab. Ideally, we should go to the next line, and that should be preferably bev based along with the chemotherapy. Though we can continue 5-FU based along with the bevacizumab, but the margin is better. I mean, better if you prefer cetuximab as a first line. The same was seen in other line also. And there is a role of maintenance also. There is a role of because oxaliplatin may lead to sensory neuropathy. And I mean, there are few trials which suggest that after 6 cycles of Folfox or Folfiri, or Folfox, we can stop the oxaliplatin. We can continue 5-FU along with that. And once the patient, I mean, the disease burden is again coming back and the patient progresses, then we can reintroduce oxaliplatin also. So there it is also in the practice, and it can be combined. Folfiri also can be used as a first line, and it can also be irinotecan is almost equal as oxaliplatin, but preferably most of the physician, I guess, they prefer oxalic over irinotecan. Next, please. So phase 2 and phase 3 trial have investigated de-escalation maintenance for treatment if anti-EGFR plus chemotherapy. So there are many phase 3 and phase 2 trials which have showed that we can give a targeted EGFR along with the FOLFIRI or FOLFOX, whichever, and we can continue cetuximab. So there were trials which showed that there was no benefit of continuing over a period of time. Some trial have showed the benefit, and these are the trial which they have mentioned that they have shown the maintenance of cetuximab along with the chemotherapy, or even the maintenance of only with the targeted cetuximab also alone had showed benefit in case of PFS other than the only observations. So these trials show the benefit. Next, please. So there are landmark trial like this one, the maintenance strategy after anti-EGFR based induction in metastatic colorectal cancer. This is a meta-analysis which has showed that when we combine anti-EGFR along with the doublet, maintenance is beneficial, and it is more beneficial in the terms of if the tumor was located in the left side tumor, where the benefit is even in the medium, PFS benefit was more. So it is recommended to go for maintenance cetuximab, and OS was also seen, but though it was not significant, but it was demonstrated. Next, please. So anti-EGFR therapy, receptor maintenance therapy in metastatic colorectal, another piece to puzzle. In this, though underlying the biology of the disease, anti-EGFR resistance is of paramount importance, especially when it comes to identifying the best strategy after achieving the maximum response. So there is a concern that if you give anti-EGFR for long period of time, the patient will develop resistance and will lose the line of treatment. So there is a thinking that we can stop the maintenance for some period of time and we can reutilize once the disease progresses. But it is advisable in many studies that if tumor is left side, it is preferable to continue it on. And the second mechanism we can use intermittently that can also be utilized, but preferably to continue it if it is left-sided tumor. Patient who are on right side, they are more likely, they don't, get that amount of benefit if we continue. And it is mainly concerned about left-sided. In that we can continue with maintenance. Next, please. So this is a phase 3 study of FOLFIRI plus cetuximab, where it was compared with FOLFIRI plus cetuximab, followed by cetuximab either alone in maintenance and patient with the RAS. This was the Hermes study, where the cetuximab along with FOLFIRI was given, and either 8 cycle of cetuximab FOLFIRI or cetuximab maintenance was given as a monotherapy. So in this, what as a clinical factor to select maintenance, cetuximab monotherapy. So the result of the trial showed that monotherapy was not beneficial. Cetuximab plus FOLFIRI was better as compared to cetuximab monotherapy alone. Next, please. So once the patient progresses on cetuximab, as I already mentioned previously, there is no point of switching to any other anti-EGFR. We can go for the next new drug that may be the VEX-directed therapy that can be bevacizumab. Next, please. So this slide shows that if we have utilized anti-EGFR as a first line, then the benefit of even giving bevacizumab as a second line has a much better benefit. The PFS was better if we have utilized anti-EGFR as first line as compared to if we have given anti-VEG first and then if we have reversed vice versa. But it is not the case. If we utilize cetuximab followed by BEV, then the benefit is more as compared to BEV followed by cetuximab. And these graph clearly shows the better PFS in terms. Next, please. So starting with cetuximab plus chemo can provide benefit over bevacizumab plus cetuximab, at least in the terms of left-sided RAS wild tumors. And this is the first line treatment where we can clearly say that most of the patient are able to go for second line and even third line if we prefer cetuximab plus chemotherapy, as compared to if we give bevacizumab, cetuximab. I mean, the patient from the second to third line, the patient load gets down. So preferable to go for cetuximab plus chemo in case of RAS wild type and left-sided tumor. Next, please. So treatment in RAS wild type right side is very tricky. Next, please. So these are the ESMO guidelines which suggest the role of anti-EGFR plus doublet are recommended in patient with RAS wild type tumor only when cytoreduction or high response to for conversion therapy is the goal. As various guidelines in ESMO and ESMO has suggested that high response is there if we give anti-EGFR therapy. The response is mainly, it is advised to give to see the conversion. Conversion is better in case of if we give anti-EGFR therapy as compared to bevacizumab. Next, please. So this slide shows that when cytoreduction is the goal, cetuximab plus FOLFIRI or FOLFOX, either one of is an effective treatment even for the right-sided wild-type CRC. Next, please. More patients achieve early tumor shrinkage with cetuximab plus FOLFIRI than with bev plus FOLFIRI, and this can be seen in this also in the 5-3 trial where the cetuximab plus FOLFIRI had a better reduction, 57 achieved ATS as compared to 41. Next, please. Only cetuximab plus chemo lead to numerically higher response rate than bev plus in patient with right type. This is also one of the trial, 5-3 trial, which has showed the conversion rate, even the uh, response rate, tumor shrinkage rate was better when it was wild type CRC, even in the right side of the tumor. Next, please. So, coming to the end of the presentation, ESMO guideline changes reflect the shift in the metastatic CRC. There is increasing test for the biomarker. All cases should go for NGS, and we should get to the know what biomarkers are positive. The metastatic CRC treatment landscape has evolved completely. NRAS, KRAS, BRAF, these are the three most common we are doing in our routine practice. And ongoing research may help to provide further personalized the treatment landscape over a period of time. Next, please. So the summary of my presentation is anti-EGFR plus chemo are now recommended as only option, or if not only option, it is the preferable option in left side of RAS wild type as per as all the standard guidelines as of today. And we should prefer anti-EGFR at least in maintenance part, those who are RAS wild type left CRC, because it will give a better PFS as compared to intermittent maintenance therapy. In right side also, anti-EGFR can be considered if we are targeting cytoreduction, and it showed good overall response rate. Thank you.
Thank you so much, Dr. Abhishek Charan, for that very elaborate and lucid talk. It was wonderful listening to you. Now, may I request Dr. Aditi to kindly invite moderator and panelists for the next talk, please?
So now going ahead, now this is a session on hepatocellular carcinoma, systemic therapy and HCC myths and facts, and to moderate it, the dynamic Dr. Lalit Sharma sir. And the panelists are Dr. Karan Kumar, hepatologist, Mahatma Gandhi Hospital, Dr. Jitendra Pahlajani, senior consultant, medical oncology, HCG Cancer Center, Dr. Abhishek Sharma, consultant, medical oncology, Goel Hospital, Jodhpur, Dr. Pulkit Nag, consultant, medical oncologist, Apex Hospital, Dr. Manoj Mahajan, director and senior consultant, Pacific Medical College, Udaipur. Sir, please go ahead. Thank you.
So once again, thank you so much. And if I see Dr. Karan in any hepatology meeting, I always feel that the learning going to be very good. In fact, thank you so much, Karan, for joining us. And Dr. Karan is very dear friend of ours. We are working together and truly loved. In fact, after working with him, could realize the hepatic aspects of many diseases, including cancer and non-cancerous things. So without wasting much time, we will be briefly touching upon the aspects. So this is a bit new pattern that we will be seeing some myth and we will be checking for the facts and we will be discussing. So let us start with the first thing. So the myth was that immunotherapy, upcoming modality. I think immunotherapy is very much into the treatment of HCC for many years. Dr. Karan, you have worked with the hepatobiliary big center, ILBS. So since when did you
Yes,
start
sir.
using the immunotherapy? You were involved in trials also.
Yes, sir. Sir, atezolizumab, before this atezolizumab, we first used nivolumab when I was a resident doing my residency during 2018. I remember the first indication for nivolumab came for sorafenib progressor and sorafenib intolerant. In ILBS, sorafenib, as it was poorly tolerated, there were many patients in which we tried with nivolumab and have seen a good response. After this atezolizumab, this IMBRAVE 150 atezolizumab was approved as first line from nivolumab. There has been shift to atezolizumab now.
So I think the atezolizumab is one of the most important part. Dr. Pulkit, when a patient comes to you and you decide to give systemic therapy, do you do the upper GI endoscopy in all patients and check for varices or it is not needed?
So especially for metastatic HCC, if I'm planning AT plus BEV, I do go for the upper GI endoscopy to check with the esophageal varices in view of preventing bleeding by giving specially bevacizumab. So I do go ahead with the upper GI endoscopy, sir.
And how about doing biopsies from the liver? You do or you don't feel like to do biopsy in otherwise
Sir,
patients?
if on the triple phase CCT scan, if I have a clear cut greater than 2 centimeter lesion with arterial enhancement and venous washout with AFP greater than 200 or 400, then there is no requirement of doing the unnecessarily biopsy. So if the radiological biochemical criteria has been met, then no need of doing the biopsy, sir.
Has Dr. Abhishek Sharma joined? Dr. Lalit, can you see him? So, meanwhile, till he comes, is Dr. Manoj also available?
Yes, sir. I'm there. Good evening.
Yeah, Manoj. In fact, I believe that you are traveling for last 3 hours, so you are going to Kumbh nowhere else.
No,
Correct?
no,
If
sir.
I understood rightly.
I'm traveling in Udaipur. I had one function to attend, so I had gone and now I'm coming back.
अभी कोई भी गाड़ी में दिखता है ऐसा लंबा 3 घंटा तो एक ही सवाल आता है कुंभ के जो जा रहे हैं
सर हम कुंभ हो क्या है लेकिन
Very good. Thank you so much. So,
Yes.
Manoj, from your side, like, do you do upper GI endoscopy in all patients before giving systemic therapy or only with BAF?
Yes, sir. Only like BEV alone is as of now, it is not a recommended choice because we have multiple choices. So we usually give AT plus BEV together. So we definitely go for upper GI endoscopy
Dr. Karan,
before initiating the.
last words from you that which are the patients where the upper GI endoscopy actually not needed?
Sir, answer is all patients should undergo upper GI endoscopy, whether we are planning atezolizumab or even any other mode of therapy. Basically, upper GI endoscopy will tell you about the portal hypertension. Cirrhosis with portal hypertension, vis-a-vis cirrhosis without portal hypertension, they are two separate groups. Those who are having portal hypertension, they are likely to have advanced disease, per se advanced liver disease. Even if we are planning resection in them or even TACE in them, they are at higher risk of developing post-surgery or post-stage decompensation. So, per GI endoscopy in all cirrhotics with HCC should be done, sir.
So I think that is very, very important, not only to see for the bleeding, but the portal hypertension itself puts them at high risk of whatever treatment they use. So good. Thank you so much, Dr. Karan. So this was about the varices part, and this all we will be going ahead. So, Dr. Pulkit, coming back to you, like in which subset of patient you feel atezolizumab is the best strategy for you? Metastatic HCC, no local treatment, systemic therapy is to be given.
Sir, in my clinical experience of 1 to 2 years, I have just have two patients of it. And the patients did not have varices. I did where the upper GI endoscopy. One was done outside only, one I went for it. So with varices, I have no any experience, but without varices, both these patients did well, sir, with 80 plus BEV.
Dr. Manoj Mahajan, from your side also, you are convinced that Bev-Atijo is most suitable combination for most patients with or without varices?
Sir, if there are mild grade of varices, I think we should address it to treatment, like my hepatologist friend or upper gastrophysicians do banding patient is child pug A. So I think we can address that, intervene that, and then we can go for combination.
I think that is also very important. And Dr. Karan, like we all are very fond of child pug A or B or C.
Yes, sir.
So probably in the modern era, that is not the right way to guide the further treatment. So which guideline and which protocol, BCLC or something else, like you use various scores. So can you tell us which score is better?
So I would like to first answer this bleeding part. Very recently, just few days back, we have published a multi-center study from India in which we have enrolled from 5 centers 160 patients with advanced SCC who were on atezolizumab. This is real world life experience from India. From one center was MGH, Hyderabad, PGI, and one from Bombay and ILBS. So what we see that the actual real life bleeding rate was 7%. Out of 160 patients, only 7% of the patient actually had GI bleed, this variceal bleed post this atezolizumab. So it is actually a more feared complication than practically what is seen in practice.
Right.
So this is one aspect. Regarding the severity of the disease, which guides the therapy, apart from this CTP score, the child book score, the focus is now on ELBA score. ELBA score is albumin and bilirubin. There is again a calculator for it. If the patients are having low albumin, low bilirubin, then they are better suitable for this systemic therapy. Rather than relying in CTP score, there are two components which are subjective, as encephalopathy and grade of ascites, which can patient may be having achieved one doctor perceives it the low grade one, other may not. So ELBA is more subjective way to underlying determine the severity score. And third thing regarding the selection of patient, one our liver society, the Indian Association of Study of Liver Disease, they have modified the BCLC classification. The advanced group, the original BCLC group, both portal vein invasion as well as extrahepatic mets into one group BCLC-C. They have subgroup divided into the two part. Those who are having portal vein invasion, they are C1. Those who are having extrahepatic mets, C2. In C1, atezolizumab systemic therapy plus if loco-regional therapy is possible in either in form of SBRT or TARE, in metastatic disease only atezolizumab. This is the practice, matlab, Indian societies which they differ from the Western counterparts.
Yeah, thank you so much, Dr. Karan, for excellent input. And again, like in continuation to this score, which score is dynamic, like you keep monitoring that repeatedly?
So that is the LBI score. Again, it is a dynamic one. And CTP, again, you can monitor it dynamically. CTP, but still standard of care wise, it's still CTP, child book score.
Right, right. Good. Thank you. Any other input from any of the panelists in between? Like
Even the RT plus BEV, the main trial, I think this trial has used child pug A only
Yes.
for eligibility criteria.
Yeah.
Yes.
Dr. Pulkit, so when a metastatic HCC patient comes to you with a fear factor, sir, liver में cancer है, surgeon ने मना कर दिया है, so what is your expectation? How do you tell them, like how much time you tell them, and how do you counsel that patient, palliative setting?
Sir, frankly speaking, any liver cancer patient above BCLC stage B, I'll consider it as on palliative setting only, sir. Anything around BCLC 0, around 1 or 2 can be considered on a curative intent, but anything beyond C is, for me, is the palliative intent.
Dr. Manoj, you also agree, or you have some?
No, sir, I'll agree with Dr. Pulkit. I think sometime we have to call it a day.
Karan, your views?
I beg to differ in this. Patient with HCC, they don't die of HCC, they will die of underlying liver disease. If the patient is having well-preserved liver, we should give them a chance there are chance, atezolizumab and other this immunotherapy, they offer 7 to 10% patient can have complete response,
Yes.
70% rate of objective response rate, this overall response is stable disease and partial response. So that is the thing. If the patient has advanced underlying liver disease like child puke C or child puke B9 or B10, then the median survival because of liver disease, even without cancer, is only 5, 6, 9 months. So my counseling depends upon what is underlying liver status. If the patient is child A, well preserved, I definitely give them a chance.
I think that is very, very important lesson for us that many times as oncologists, we focus towards only cancer. We don't focus towards the remaining liver part, whether how much damage and how much cirrhotic and what is the current. So very rightly said that many patients do die of the liver disease rather than the cancer itself. Very good. Thank you so much, Dr.
Sorry to interrupt. Dr. Abhishek Sharma is also now available with us.
Okay, Dr. Abhishek, can you pitch into the palliation part of HCC?
Yeah, definitely, sir. So those patients as a child took C and child took B class, definitely they had a poor prognosis. So yes, but about the advanced class, especially C, because till B we are away loco-regional therapies and option of liver transplant. But for a C, I agree this patient is palliative. For those who are exceptionally responsive with the systemic therapy with well-preserved liver functions, then we can take a chance for some. I think some study are there, sir. After that, at each of babe, some patient consider for liver transplant. There is some studies, so we can go for that.
I think that is very, very important that like we should give them a chance rather than declaring that no, this is liver cancer, metastatic, whatever it is, like pure palliation. We should give them a chance, and because it's the biology ultimately which is the king. And Dr. Karan, to me, it appears that we all have used like more of sorafenib and the lenvatinib. Now we don't use anything beyond that majority of the patients. So probably because of that, the medical oncologists feel that the overall outcome is not that good. So, Pulkit, like, do you use the neoadjuvant setting also the treatment and make them optimal?
Not yet, sir.
Okay. And how about Dr. Abhishek? Do you use the neoadjuvant setting?
Sir, yes, sir, definitely. It's because if it is patient in class A or B, sir, definitely for class A, this is it's all up to hepato surgeon what they are going to be do plan. If you for a class B, there is a data, sir, something we can plan patient for some new adjuvant treatment with the TACE or TARE, then consider for a patient as a good response, then it's a candidate for transplant, we can consider for it. Even some good data right now is going on with some trial right now, some trials following STRIDE protocol with the TARE and some STRIDE protocol with TACE. And they are considering as a new adjuvant part, and they are planning to for some localized therapy for that patients. So new adjuvant, we can plan for that patients. It's all, it should be a MDT decision basically, sir, because what your hepatosurgeon is going to be done and what as a oncologist you are going to be done. So it should be as a part of MDT.
I think that is very important, especially like we are lucky that we have a dedicated hepatology team with us. Dr. Karan is there. We have a dedicated hepatobiliary surgery department also. And like after seeing the benefit from the teamwork, now I can see the approach to the HCC metastatic is not that bad. And even if the patient is like for a window period, if you have scheduled for transplant, it is not going to happen like we discussed today and tomorrow it's going to be transplant. So by the bridging part, we can continue the systemic therapy for these patients. Dr. Karan, do you want to say anything else?
Yes, sir. This new adjuvant immunotherapy as of now till date is not recommended as a adjuvant. Other modalities, microwave ablation, radio frequency ablation, SBRT stays there. They are used as a bridge to transplant. Some patients not intended to be bridged by this immunotherapy. They have shown a good response that tumor was initially out of transplant criteria. Patient responded very well to this adjuvant therapy, this atezolizumab, now become transplantable. They were taken up for transplant with good response. So in that way, they were used as new adjuvant, but not with an intent. Regarding this adjuvant thing, only one trial, IMBRAVE 050, which showed improved overall survival with atezolizumab, but no difference in PFS. So again, that adjuvant IT wala is still a gray area of using atezolizumab.
Right. Thank you. So, coming back to Dr. Abhishek, that does the etiology, whether this is like alcoholic or hepatitis or the NASH or the NAFLD, does it make any difference to you feeling the outcome?
Yeah, sir. Basically, sir, the most common agent we all know that some underlying liver disease, any due to substance abuse or due to some viral etiology. But right now, I think NAFLD, non-alcoholic fatty liver disease, is the most common. You can say not a most common. It's an increasing cause in young age HCC. So when we discuss about the IMWave 150, their subgroup analysis in favor of that non-viral etiology, the hazard ratio is near to 1. So in a viral etiology, here hazard ratio is around 0.78. So yes, sir. If patient is a non-viral etiology and patient is not so affordable for immunotherapy, yes, we can easily say, yeah, you can go for some TKI in that condition. So because we have some kind of data for that non-viral etiology, HCC had a more or less similar response with TKI and atezolizumab combination.
Great. Dr. Pulkit, question to you. If a patient comes with hepatitis B virus positive, like whatever the DNA load may be, and the patient is HCC also. So how do you handle both these things together?
So, sir, in fact, I had this one same patient with me. So, first of all, I'll take the opinion of my gastroenterologist colleague, and we'll try to start to manage the first hepatitis B, and we'll wait for a week to come down the viral load with the help of the quantitative PCR DNA analysis. And then we'll start after doing upper GI endoscopy, everything. Then we'll start with the dual agent of AT plus BEV. So, targeting the HBV viral load plus systemic therapy and immunotherapy would be my choice, sir. I did it in my one patient, sir, and he's doing okay till now.
Great. Dr. Karan, any input like for how long should we wait and where should we start the antiviral treatment first before starting the treatment for cancer?
Both the things can go simultaneously. In fact, for HBV without HCC, nivolumab is being tried as a therapeutic drug for treatment of HBV.
Okay, so both can be given together.
For hepatitis B treatment, nivolumab is being now tried in phase 3 trials. So there is no need to wait for this. You can start antivirals and nivolumab, this immunotherapy atezolizumab together. In fact, the subgroup analysis of this IMBRAVE 1, they have shown better result in viral HCC as compared to this non-NASH patients. So Hep B plus SC, they've taken combined, they have better result with atezolizumab. So both the things can go parallel. There's no need to give a waiting period before starting atezolizumab.
So I think the etiology doesn't make much difference, but Dr. Karan, to us appears sometime that the infected tumors, they have much more of antigenicity.
Immune
But
response,
studies suggest that there is no significant difference. So etiology doesn't make difference, and the etiology for systemic therapy we have discussed. So this is again very, very important, Dr. Manoj. Back to you. So, how much survival you tell patients normally, usually with a metastatic liver disease?
So we tell the PFS data, but on an average, we say 1 to 1.5 years. And in terms of like, we have few patients who have gone more than 3.5 years.
Yes.
Still on maintenance, but that is what we have to share the data to the patients, whatever data we have, and explain the data to the patient, and also explain the few examples who are like long-term survivors. So that gives some positive confidence to the patient for initiating the treatment.
Very right. Dr. Abhishek, you also share the PFS data to patient because we are hesitant, the kind of patient we get, we are hesitant honestly to show them the graph and the PFS part. We just tell them that yes, we will give some treatment and we hope that you will be getting benefit. But the quantification of time and other things, usually we are the kind of patient we are getting not doing. So Abhishek, any inputs of that?
Yes, sir. Yes, sir. Definitely, sir. Because before the era of TKI, the advanced stage HCC definitely few months survival. Even we can talk at that time we can talk about the PFS also. Just we say कि you have a few months and you are going to go. But after the TKI, we have a PFS of 3, 4 months or 6 months and survival up to 10 month, 11 month, 12 month with the all TKI. Then comes to the immunotherapy at wave that have a median OS around 18 months and some IO combination right now we have. So that is a bit quite good overall survival. Even right now, I think sir IO combination their 5 year data is suggestive of 20% advanced stage survival. So that is quite good, sir. If when we talk about the for SCC palliative setting, 5 year overall survival is at 20% is good. Even when you go for a 3 year survival or 4 year survival in IM in 150, it is quite good actually, sir. So when we talk about the median US, yes, definitely you can say ki you are going to be alive around 18 months, but we can show evidence of ki, the patient who survived up to 2 years, the patient who survived up to the 3 years. So now few months is a myth actually, sir, with the immunotherapy and combination is right now not in few months.
Dr.
And sir,
Karan.
we should include it few years rather than few months.
Yes, sir. Yes.
Yeah, in
Yes.
fact, again, like we should not, to me, it appears we should not quantify the time to the patient,
Yes.
but like गोलमोल बताते हैं कि यार few months तो इससे निकल जाता है, मे बी से 8 महीना, 10 महीना, 12 महीना, किसी किसी का 12 महीना से भी ऊपर हो जाता है, साल 2 साल भी हो जाता है. Because long back I like tried to quantify during the training in Tata Hospital. So I told the patient that yes, it looks like 3 months based on the. So patient survived for more than 3 years. So during the whole tenure of mine Tata Hospital, he was sending a postcard at that time. Postcard was very popular, very cost effective. He was sending letter to me and to my director that Dr. Lalit Mohan Sharma has given us 3 months. मैं 6 महीने के बाद लेटर भेज रहा हूँ, 9 महीने के बाद भेज रहा हूँ, ये 15 महीने के बाद भेज रहा हूँ. तो देन आई फेल्ट कि आइंदा किसी को टाइम बताया. आई टेल पेशेंट मुझे मेरा ही टाइम नहीं पता, मैं आपका क्या बता. But like we all agreed, it's not usually in months, it is in.
Yes. No, sir,
Dr.
but
Karan,
sir, you have, sir, you have seen the whole evolution of the oncology treatment. When you were in training, there were
Yes,
hardly any
yes, very
concrete therapies. So now probably you can start telling the time, which is more than 3 months. First thing,
in
and
fact, when the sharp trial came, it was like a big magic. We all felt it. HCC, we have got some TKI, some oral pill which gives like 6, 7 months or 8 months.
9 months.
So it was a
and
magic. And for many
and
years, we sharp was
Sharp
this and
and
nothing else.
with
Dr. Karan,
immunotherapy, the only thing is like we can show like almost 10%, 5 to 10% patient have CRs. That
yeah,
is the
very
probably one
definitely.
of the positive side where we can always say patient these many patients will have CR, and which is documented, and even in the real world
Seen
also we
also.
see similar kind of numbers. So that number, and if given a chance, if we uh, do away with the finances, if patients are financially eligible, so everybody will take, even if there is 1% chance patient will agree for that.
I
This is
think
why my
that's very important
Very
that
true.
the patient's fate you cannot decide. Even 10% patient may go into CR. So we don't know the person sitting in front of me, how he will respond. So why we should take that decision by us based on the patients, whatever it is. So we should be very honest with them. I usually tell them that immunotherapy sometimes work in a very good way. In many patients, they have a prolonged survival as well. Dr. Karan, how long
Yes.
the longest survival you might have seen the maximum number of HCC amongst any of us. So how much is the longest survival you have ever seen in metastatic HCC?
So as you were telling, similar experience in my residency, I consult one patient that nivolumab, don't give nivolumab, बेटी की शादी करवा लो, ज़्यादा better, इतनी महंगी दवाई दोगे.
Yes.
He keep on following me till 22 from 2018. He is a complete response. He was a lucky responder and still alive now. 6 years now.
So that's a great
7 years.
thing.
Uh,
So, in fact, sometimes we get miraculous results. So again,
yes.
Vertigo is one of the good combination if the patient, like we can deliver it to the patient.
Actually, sir, as Dr. Abhishek was pointing, na, if you see the Himalaya trial curve, the
Yes.
Kaplan-Meier, the difference start appearing at 12 or 16 months onward. Once the patient who have survived 16 months, they are the one who maintain their survival and the response, and they live longer. So if a patient on immunotherapy, what I believe is if they live for 14, 16 months with a good response, they are the one who are going to live longer.
I think that is very, very important that in most of the cancers, if the person is showing good response to immunotherapy, that patient is likely to continue showing good response. I have one head neck patient, in fact, who had very, very early relapse, and then we have treated with immunotherapy at that time. He was CGHS beneficiary. So now the disease which had like need for all the immunotherapy, the chemotherapy, cetuximab, all those things. Now the patient is disease free for last more than 4.5 years. So a person who had like no treatment left over, now he is sailed through in 2 years after the Nevo, all the PET CRs are coming negative. So this was the issue like BCLC 2016 with systemic therapy. Advanced stage was 10 months. And now we can see that the advanced stage C also like the patients are surviving for more than 2 years. We have Bevatijo, we have the Himalayan trial, and then we have other drugs also in the second line and third line also available to us. Immunotherapy does work in patients with high tumor burden. So, Dr. Pulkit, do you do EMD or anything in patients who are affording?
So I think we still again the same, the combination of immuno with bevacizumab that works in the high tumor burden patient. Single agent, sir, I have no experience of that, but I think the best is to use the combination of bev plus immunotherapy because immunotherapy is a slow acting drug and bev is a little faster acting as compared to the immunotherapy, and both have different mechanism of action, which in case of HCC work in a synchronizing manner, increasing each other effects. So I think the combination of AT plus bev obviously works better in the patients with high tumor burdens.
Very, very right. Dr. Manoj, uh, Manoj, can you unmute?
Yes, sir. Yes, sir.
So if a patient has got a large tumor along with metastatic disease and you decide for taste or tear, how do you sequence the taste should be done when? Dr. Karan, we will just take 2-3 more minutes.
Yes, sir. Yes, sir.
Yes. Sir, question is immunotherapy doesn't work in patients with high tumor burden.
No, the question to you is if a patient is like deserving, he has got a high tumor burden, but he has a large tumor also, and the MDT and your IR person feels that taste can be done for this large lesion, and then you can continue systemic therapy. So how do you sequence taste and the beverages?
Sir, usually we go for taste first, and then usually we start bevatizo.
So I think that is important, Dr. Karan, correct me that the inflammation related to the taste or the tear, it makes the tumor cells more in the zone where they can be restricted with the Bev and Atijo part.
Yes, killing of the tumors by doing this test, they will release more tumor antigen into the circulation, and at that same time, if you invigorate the immune response by giving this immunotherapy, then it tends to act more. So test followed by atezolizumab.
So in fact, these are all pictures which we see in our daily practice that the metastatic disease that also shrinks with these. Immunotherapy works in young population. So Dr. Abhishek, anything related to the age response to immunotherapy? Pulkit, you can take this. Does age make any difference?
No, sir. I think nothing. No, sir. Matlab, the patient which I am having is older age only, 62 years old. So we have seen that it works good also in older age patients. So no very major difference between young and older populations, sir.
I think if we see this trial also like 50% of the patients were of more than 65 years of age. So age probably does not make them worse and we should not give any discount related to the age. Dr. Karan, correct me for anything else you want to add.
True, sir. True.
So the last question is for how long do you continue the Bevatijo? Dr. Manoj, if the patient is responding, no financial barrier.
Sir, as long as possible. I think one of my patient is almost 3.5 years.
He's continuing with Bevatijo?
Yes, just there is a little bit modification. We are giving like four like once in a month. Patient now comes 4 to 5 weeks, once in 4 to 5 weeks.
Dr. Abhishek, you also agree that if the patient is showing good response rather than being too rigid, we become little liberal in increasing the gap between two doses?
Yeah, sir. Yeah, sir. Because अगर हम we just talk about the trial, so continue till progression, continue till unacceptable toxicity. Agar patients are very well respond with the treatment, I'll continue with that. And yes, as per patient convenience, we can increase the gap, sir. Because as we all know, there is a effect of immunotherapy that go long on. And even some trials, yeah, sir, we already saw that some 6 cycle, 2 cycle, given that.
Right. Dr. Karan, last question to you.
Yes,
If
sir.
the person is showing good response to whatever treatment like TKI plus Bev or Tijo plus minus stay or whatever we do, if the patient is showing good response, can we consider transplant also at some point of time in such patient?
Yes, sir. Sir, initially there was a doubt for doing transplant in patient post immunotherapy. Post transplant, we have to suppress the immunity by giving strong immunosuppression. Before the transplant by immunotherapy, immune responses enhanced. So there was all a fear in the mind that if a patient is on immunotherapy and then he's being taken up for the transplant, there is a risk that patient can reject the new organ. There can be possibility of immunological rejection because the immune response is heightened. But gradually now the experience is building up. Now the consensus is give it washout period of 3 to 4 half-life of the drug. For atezolizumab, it is approximately 3 to 4 months from the last dose to when the patient is being taken up for transplant. If you give up that period of time, 3 months or 4 months of waiting from the last dose to the transplant, then there is no increase in rejection post-transplant. So patient can be taken up for transplant even after immunotherapy.
So I think
With the
that
caveat
is
that there should be a washout period of 3 to 4 half-life of the drug which are being used, which are being given to the patient.
So I think that is also very, very important that not only the patient show good response, but in good responders, we may consider the potentially curative treatment also. So HCC is not that bad, which like we have seen in our initial days of life. So I think in the interest of time, we will stop here. And Dr. Karan, last word from your side.
So we should uh, give a chance, just as you have suggested, give it this approach all the options which are available to the patient. You can choose TKI. These are the options available. Let the patient take the call rather than we taking the call on their behalf that it is costly, giving only 6 months, take 10 months.
Agreed. Pulkit, from your side, last line.
Sir, I think that AT plus BEV, I think it's being a booming help in metastatic HCC patient. So I think just hoping to get more patients like that so that we can help them down with this combination, sir.
Thank you. And Dr. Abhishek, from your side, last words, metastatic HCC.
Yes, sir.
So you also agree with the same?
Yes, sir, definitely. Agreed.
Manoj, from your side?
Sir, we are better served getting letters of 3 months and 6 months from like you because of availability of these drugs in our era.
So I think very, very important, not only the prolongation in patients getting into the CR, we may consider liver transplant also. That is very, very fascinating field for me. So I think with this, we conclude this session. I thank Dr. Aditi, Dr. Lalit Sharma for giving us an opportunity. And I'm a special thanks to Dr. Karan. He is busy with the family issues, in fact, at this time. So he is getting repeated threats from the kid that please come. So thank you so much, Dr. Karan, for your excellent tips. We truly enjoyed and learned.
Good evening, sir.
Thank you so much.
Thank you so much. Thank you so much for that wonderful moderation as always. Thank you so much, esteemed panelist, for your wonderful insights and a very fruitful scientific discussion. Now, to move on, now is the time for the showstopper. A very dear friend of mine, Dr. Rohit Swami, wonderful orator. He's a senior consultant medical oncologist at Narayana Multispecialty Hospital, Jaipur, and he will be speaking on durvalumab plus gemcitabine in the is the new standard of care in the advanced BTC. Over to you, Dr. Rohit.
Thank you, Lalit boss, for such a generous introduction. So, can someone please share my slides? Yeah. So I'll be presenting role of durvalumab in advanced biliary tract carcinomas. Next slide, please. And India is having the most incidence of the biliary tract carcinomas and most common and largest number of incidence of gallbladder carcinoma is in India only. And in India, this biliary tract carcinoma is generally associated with biliary stones, except in North India, where without biliary stones, there is majority of incidence of gallbladder carcinoma. Next slide, please. And 90% of these biliary tract cancer are diagnosed in unresectable or advanced stage in India, and the incidence of these biliary tract cancers are both increasing in males as well as in females. Next slide, please. Coming to the current management of biliary tract carcinoma, so NCCN guidance. Next slide, please. Next slide. So till 2022, NCCN guideline endorsed gemcitabine and cisplatin as the first line therapy for these advanced biliary tract carcinoma. Next slide, please. And this was established after ABC2 study, which showed that GemCis gives survival as well as PFS benefit as compared to single agent gemcitabine only. Next slide, please. And then several other retrospective study like this match pair analysis was done at the Tata, which showed that GemOx can be the alternative of the GemCis, but GemCis still give higher EFS as well as lower incidence of peripheral neuropathy, lower cost, and lower hepatotoxicity. Next slide, please. And then studies were done that whether continuation of maintenance gemcitabine can give us PFS benefit. So there was significant PFS benefit with the maintenance of gemcitabine after 6 cycles of GemCis. Next slide, please. And continuing chemotherapy in certain subgroup of the patient who are suffering from the advanced or metastatic biliary tract carcinoma can give survival benefit, especially in those patients who are with a good PS and who are going to receive second line of chemotherapy also. Next slide, please. So here come the hypothesis that some kind of maintenance therapy can be given in these advanced biliary tract carcinoma. Next slide, please. And the study came, phase 3 study Topaz 1, which compared durvalumab with GemCis as compared to GemCis alone and followed by durvalumab maintenance. Next slide, please. So locally advanced or metastatic biliary tract carcinomas, either previously untreated or previously resected and recurrent disease within 6 months after adjuvant therapy, were randomized into 1:1 fashion into durvalumab gemcis arm as compared to gemcis placebo, and both were followed by durvalumab or placebo maintenance. These patients are further stratified according to disease status as well as primary tumor location, whether these were intrahepatic, extrahepatic, or gallbladder carcinoma. Primary objective of this study was overall survival. Secondary objectives were progression-free survival, objective response rate, duration of response, efficacy as per PDL1 status. Next slide, please. Baseline demographics and characteristics were well balanced in both the arms. Majority were around 64 of the age was the median, and Asian population was 55%, Caucasian were around 40%, and the most common tumor was intrahepatic cholangiocarcinoma followed by gallbladder carcinoma. Next slide, please. And MSI high status was seen only in 1% of the patient, and PDL1 high expression was seen in around 60% of patient in both the arms. Next slide, please. And at the data cutoff, around 81% of the patient in the durvalumab discontinued as compared to 94% of patient in GemCis arm discontinued treatment. So 18.6% of patients were still on treatment in durvalumab as compared to 5.8% only. And around 50% of these patients in both the arms received further second line therapy. Next slide, please. So coming to primary endpoint, there was significant survival benefit with the addition of durvalumab as compared to GemCis alone. Median overall survival was 12.9 months as compared to 11.3 months with hazard ratio 0.76. And this survival benefit was maintained even at the 2 years with the survival probability at 24 months was around 23.6 months in the durvalumab as compared to placebo. Next slide, please. And this overall survival benefit was seen in all the subgroups, whatever the age, whatever the gender of the patient was there, and whatever the location of tumor was, and whatever the PDL1 status of the patient was. Next slide, please. And coming to the PFS, so there was significant PFS benefit with addition of durvalumab of 7.2 months as compared to 5.7 months in placebo arm. 12-month PFS probability was around 16% as compared to 6.6% in placebo arm. Next slide, please. This PFS benefit was also maintained throughout all these subgroups as mentioned earlier. Next slide, please. Overall response rate, so there was significant better overall response rate of around 24.6% as compared to 18.1% in placebo arm. Next slide, please. Next slide. So 12-month overall survival was around 26.1 as compared to 15-month. Next slide, please. And duration of response was also better in durvalumab, around 26.1% overall duration of response probability as compared to 15%. Next slide, please. And among the responder, generally the patient who maintained stable disease, the stable disease was started from the 6th month, and the patient who had PR and CR, that was continued 15 months and even higher. So duration of response was further maintained in the patients who were responders. Coming to safety indexes, so adverse events were almost similar in both the arms, and most of these adverse events were because of chemotherapy arm only. Treatment related adverse event which led to discontinuation was only 9% in durvalumab as compared to 11.4% in placebo arm, and leading to death was almost similar in both the arms, and immune-mediated adverse event was almost double in durvalumab arm. Next slide, please. So as we can see that most common treatment-related adverse events were because of chemotherapy arm, which was neutropenia or anemia or thrombocytopenia. Next slide, please. Immune-mediated adverse events were definitely double in durvalumab arm, and most common were hypothyroid followed by hepatitis or pneumonitis and dermatitis. Next slide, please. And now we have in the 2024, the 3-year overall survival analysis of Topaz 1 was presented. We showed that median overall survival remained 12.9 months in durvalumab arm as compared to 11.3 months in placebo arm. And probability of overall survival was almost double in durvalumab arm as compared to placebo arm, around 14.6% as compared to 6.9% in placebo arm. Next slide, please. So as with the time the responders get on increasing the benefit of overall survival, the percentage of the patient or number of the patient increases having better overall survival. So at 12 months, around 1.15 times of the patient has better survival, and at around 3 years, it was around 2.12 times of the duration of the survival with durvalumab as compared to placebo. Next slide. So updated 3-year overall survival data gives us overall survival rate at 36 months of 15% as compared to 7% in placebo arm. That is almost double. Next slide, please. Next slide, please. So genomic alteration landscape is in this slide, which is seen in the advanced biliary tract carcinomas, most common being P53 mutations, followed by a number of mutation. Next slide, please. Next slide. And our interest is whether this combination of chemotherapy and immunotherapy is inferior in any kind of mutation of this landscape of mutation seen in advanced biliary tract carcinoma. So there is survival benefit of durvalumab in each and every mutation except HER2, though the number was very small, so we can't conclude anything from this graph. But overall, whatever the mutation this advanced biliary tract carcinoma is bearing or harboring, will be taken care of with combination of durvalumab and gemcitabine. Next slide, please. Coming to real world evidence, so we have two real world evidence, one from the Italy. Next slide, please. And this real world experience also had the demographics and disease characteristics of the population almost similar to the Topaz 1 population. Next slide, please. And similar were the outcomes. The median overall survival remained 12.9 months, around 12.3 months in the Topaz study. Similarly, median PFS was also similar to Topaz 1 trial. Next slide, please. And overall objective response rates were also similar to Topaz study. And there appeared to be increased overall response rate with addition of durvalumab. Next slide, please. Safety was also not a concern in this real world study. Next slide, please. And any immune-mediated adverse event remained 2.1%, which was around 2.4% in Topaz 1 study. So, next slide, please. Coming to Indian real-world evidence, next slide, please. So, it was multicentric Next slide. Around 12 centers throughout the India were included in this study. Next slide, please. And most common biliary tract carcinoma was gallbladder carcinoma, more common in female, seen in this study. Next slide, please. And in this study, in the median follow-up of 6.8 months, median cycle of durvalumab was received in were 3, and median cycle of chemotherapy received were around 4. And around 67.6% of the patient has the death. The CR was around 2%, PR was around 27%, and stable disease was 24.3%. So overall response rate was around 29.7%. Next slide, please. So result of this study were also similar to Topaz 1 study. Estimated median overall survival was 12 months, which was equivalent to Topaz 1 data. Overall survival benefit was seen across all the subtypes, and median overall survival was around 2 years in those patients who has clinical benefit rate, and we showed the clinical benefit from the very beginning. Next, and the patient who received low dose durvalumab had inferior median overall survival. Next slide, please. And PFS was also similar to Topaz 1 study in this trial. And coming to safety and toxicity profile, so again, around 7.4% had any kind of durvalumab dose reduction or sedation, and immune-related adverse event were seen in around 7.4% grade 3-4 toxicities. And it were again dermatitis, hypothyroidism, and pneumonitis and hepatitis. Next slide, please. So concluding real world data experience, so durvalumab and chemotherapy behaves similarly as Topaz 1 study population in the real world also. There is overall survival benefit, PFS benefit with almost similar toxicities. Next slide, please. And since 2024 now, NCCN guidelines also endorses addition of durvalumab with Janssen in the first line category in advanced biliary tract carcinoma. Next slide, please. Next slide. So concluding my study, there is significant overall survival benefit with the addition of durvalumab with Gemcis in advanced biliary tract carcinoma, and even 3-year overall survival data also uh, uh, shows the same. And there is a doubling of the survival rate with the addition of durvalumab as compared to chemotherapy alone. Coming to safety, so there is no safety concern with the addition of durvalumab with the chemotherapy. And biomarker status, so whatever the mutation the patient is harboring, durvalumab is going to help that patient, increasing his or her survival. So Topaz 1 is first phase 3 trial, which gave a standard of care as a first line GEMSIS with the addition of durvalumab. Thank you. Thank you, everyone.
So thank you, Dr. Rohit, for that wonderful, crisp presentation. So my question, the only question to you is now with this convincing data, how do you kind of put durvalumab in this particular setting in your clinical practice?
So definitely in the first line setting, advanced biliary tract carcinoma, whether it is intrahepatic, extrahepatic cholangiocarcinoma or gallbladder carcinoma, addition of durvalumab is going to give survival benefit to patients. So my first try will be to add durvalumab with the chemotherapy in the first line setting. And now we are getting PAP patient assistance program also with the durvalumab in this setting. So I think we should try to go with the first line durvalumab and Gemcis in these patients.
So I believe you would agree that we have seen a drastic change in the management of these patients with immunotherapeutic drugs such as durvalumab showing such wonderful responses. This is one subset wherein the patients usually used to have really bad responses, very poor PFS and overall survivals, but now we are gradually seeing the scenario changing.
Yeah. And at the three-year overall survival rate is now double as compared to chemotherapy. And as you said only that this subset of patient or this disease gives very less time to the patient. There is very poor survival.
So this was yeah, please go ahead. So this was a situation wherein we were clutching for straws, and these particular molecules are helping us like anything. So thank you again, Dr. Rohit, for your wonderful presentation and your help throughout the webinar. Your insights have been very valuable and have left all of us wiser. So to conclude this evening, what a wonderful evening of scientific discussion and churning of data. I hope this leaves us all wiser and helps us improve patient outcomes. I am thankful to all speakers, moderators, panelists, and attendees for their valuable contribution. I'm thankful to all sponsors, including AstraZeneca, Merck, Roche, Harris, Fresenius Kabi, Sun Pharma, Johnson & Johnson, and Dr. Lal Pathlab, for whose generous contribution has made this event possible. I'm also thankful to my organizing team for conducting this event flawlessly. They need a huge applaud. Now, last but not the least, I'm thankful to my family also, my beautiful wife Parul, my son Ridul and Maulik for bearing with me and encouraging me always. And I'm looking forward towards continuing this feast tomorrow also. We will meet again and see each other at 7 in the evening tomorrow evening. Thank you so much, everyone, for your wonderful participation and contributing so generously. Thank you so much.
Thank you, sir. Thank you, everyone, for joining. Thanks to my colleague Swarangi and Dhruv and technical support. Thank you, everyone. Good night, everyone, till we meet tomorrow.
Thank you, team. Thank you so much. Good night. Bye-bye.
Nice. Support.